Hello and welcome to the second International Stoke Mandeville Plastic Reconstructive Surgery Symposium. I'm Rebecca Shirley.
And I'm James KK Chan.
And we are connecting with you from the beautiful county of Buckinghamshire, just west of London in England.
So it's the end of a crazy year, and today's event marks the finale of the second season of our Stoke Mandeville Plastic Surgery webinar series. It's wonderful to have all of you here with us today. So over the course of 2021, we've virtually traveled to many continents and explored the boundaries of plastic surgery. There were plenty of highlights, including checking out lymphedema and phalloplasty in the USA.
Then we had artificial intelligence and extreme sarcoma reconstruction in the UK.
We also had robotic nerve surgery and voice reconstruction in Taiwan.
Microsurgical thumb reconstruction in China.
And advanced skin cancer reconstruction all the way down in the Sunshine State of Australia.
Today, we are really excited to be collaborating with our friends at the Ganga Hospital in India for this international symposium. We also want to thank our sponsors, Merced, supplier of specialist surgical instruments and medical devices, and Bone Support, the orthobiologics company that markets drug-eluting bone substitutes for bony defects. Our aim today is to stretch your imagination and inspire you, and our brilliant keynote speakers from around the world will do just that.
So there will be 3 one-hour sessions this afternoon. The first is on elite performance, and the second on trauma and brachial plexus reconstruction, and the third and final session, our best paper competition. So Rebecca, let's get to it.
Right. Let's welcome in our co-chair for the first session of Elite Performance, Tim Goodacre. Tim Goodacre is ex-president of the British Association of Plastic Reconstruction and Aesthetic Surgeons, and now vice president of the Royal College of Surgeons of England. Great to see you, Tim.
Hi, I'm just coming in. Hi, great to see you all, and thanks very much for inviting me to join you this afternoon. So that everyone knows, that this first session this afternoon is about achieving and maintaining peak performance in our practice, and clearly something which I suppose most of us as surgeons will have thought all our lives about succeeding in what we do for a variety of reasons, but we all want to make a good go of everything we're doing day by day, and particularly our surgical practice for our patients. Obviously, there's so much to learn from different disciplines, and it's always good to learn when things go wrong as well, and how we cope with those, because all of us are going to get blips, and no elite athlete has been elite forever and ever, other than the few. Even Roger Federer occasionally has a dip, and some of our motor racing guys recently. It's a great pleasure to introduce Mike Tyler, who I first met many years ago when he was a very young surgeon.
young nipper.
A young nipper, yeah. And I was less old and grey. But Mike, you have leapfrogged and had an illustrious background, and I've become ever more aware of your achievements, not just surgically, but also in your surgical science as you've gone on, and you're an all-round great guy to talk to, and have always been a voice of common sense. So Mike, let's hand over to you, and whilst we're juggling the order here, but you are a consultant plastic and reconstructive surgeon at Stoke Mandeville. You've been there for a long time. You've got a growing and really exciting department full of young enthusiasts, and it's great that you're on this. And let's hear what you've got to say about peak performance.
Thank you. Thank you very much. I'm going to share my screen. What I'm going to really talk about, in 2011, I did the Fastnet yacht race, and the Fastnet yacht race was the big boats on the show at that point were this boat that you can see, the first boat that's our Leopard of London, which is a 100-foot maxi, beautiful boat, and the really professional crew, and they were basically racing against the second boat here, which is called Rambler, which was came over from New York Yachting Club, and they'd broken the transatlantic record when they came over for the race. And these boats were just huge and massive, and they're traveling at about 3 times the speed of the little boat that I was doing the race in. And I want you to imagine these guys, they're all professional, they do their job very well. But you set off at about lunchtime on Sunday, and you sort of go into the night, you're beating, which means you're going against the wind all along the south coast of England, and then you turn right at Land's End and head up towards the south west coast of Ireland, where there's a small rock called the Fastnet, 3 miles off the Irish coast, and you go around that. And so you can imagine this is the sort of conditions they're in. It's 4 in the morning, and they're just rounding the yacht. And actually, this boat, the bulb, the keel, broke off. And so these guys who are sitting on the windward rail here would have, within probably 10 seconds, been sitting on the windward rail thinking about when they're going to have the next cup of tea. And next thing, the boat will have literally been on its side with the sail in the water. This is absolutely freezing water, even though it's August. The water's about 12 degrees. You get this huge water shock. You're in the middle of the Irish Sea. There's, it wasn't that stormy, but there's you can see there's a couple of reefs in the sail, and these guys ended up, as you can see, on the undersurface. The boat completely flipped side. Thankfully, it didn't capsize, and they were rescued after about 6 hours of sitting on the boat. They didn't even have time to launch the life rafts because everything was so quick, and obviously they got on board the boat there. And I think the reason why I've chosen this analogy, because I think sometimes in surgery we have these moments where everything is going fine, and before you know it, something happens. Usually, obviously, it's something to do with bleeding. And when you get man overboard when you jump into cold water, unexpected cold water, there are a few physiological responses that happen. We take obligatory breath, which is why people fall into the channel and drown. And you think, well, why did they drown? Why don't they just hold their breath and swim to the boat and climb back in? They're a bit chilly or whatever. But actually, physiologically, these things happen. And what you've got to do when you fall in is you've got to ride this overwhelming panic that will come across you. No matter how cool you are, you will panic. You'll be in the water, you'll have a shock, and you've got to let this adrenaline rush, the squeeze of adrenaline in your body come over you. And we get this in surgery. We have to stay calm when suddenly you get a big spurt of blood that you weren't expecting, and your mind starts to think you've got to put a swab on there and stay calm, and then very, very coolly continue the operation and things. And that's sort of one analogy. And I think that's one thing, the analogy that I get, that's when you get an unexpected sort of situation within surgery, and you need to be, like this crew here, professional, and manage it. And we're going to talk a little bit about this in coming, and how professional sportsmen do this, because obviously they're the closest to getting this sort of surge of adrenaline on a weekly or basis. We don't get it very often. And the next sort of story that I want to give is, if you have a look at this boat here, this is a Reflex 38. It's a much smaller boat, a nice little boat. And I learned to sail on a boat like this. Actually, they're quite cramped. There you can see there's not much to keep you in the boat, actually, so other than your strap. And I was due to do a race in 2011. We had the ARCP at Stoke Mandeville Hospital. I was going to join the crew afterwards, and thankfully our skipper said, guys, there's a hell of a storm coming. I don't think we should race across the channel today. We just did a training few laps in the Solent, but actually there was one of our sister boats went out, Lan, and about 31 miles south of Isle of Wight, the skipper fell overboard, and very, very tragically, and the crew heroically managed to get him back on, which is a feat in itself at 3 in the morning. But he sadly had died. And I think that's the other thing that we have to occasionally come across when we're surgeons, is this fact that we sometimes get overwhelming problems that face us, and that we ourselves are either unwell ourselves or actually it becomes overwhelming. I've been in surgery in one situation with a registrar in my junior years, when he suddenly realized he was operating on the wrong leg. and he completely fell apart, and I had to sort of step up and sort of get everything together. So we all may become in situations where we're called to step up in this sort of life-threatening situation, where either the patient, i.e. the boat has failed, there's a problem, or indeed it's us that are in the water, and we've got to do something, or we've got to step up because it's the skipper that has gone down. And so actually maintaining performance in these utterly extreme events is really one of the themes that is of this show. And so I'm really looking forward to this next session, because we've got some people that kind of know all about this, and I commend you to this next bit of the session. Thank you.
Thank you, Mike. Thank you. I'm aware we're a bit behind time, but that's some dramatic examples of things going wrong and stressful scenarios. I do want to bring Martin straight in now on this, because Martin Hagger is a distinguished psychologist from UC Merced. Merced, I'm not sure how we pronounce it correctly, Martin, but I gather America's first research university. You also have an appointment in Finland, but you have published a great deal on performance and maintaining performance, and you've got an extraordinary expertise in sports psychology and elite sports performance, which we've seen on some of your TED Talks. So it's a great honor to have you join us this afternoon. Thank you very much for coming in. And we've had some technical problems, as occasionally happens with this side of things. But I'd like to hand over to you, and then we've got lots we want to unpick about when things go right, how to make things go right, but also how you keep on track when things go wrong, whether they're catastrophic events that happen, like the wind blowing, or whether it's you when you fall apart, and when we all fall apart. So Martin, over to you, and thank you very much for joining us.
Or when you can't get onto a Zoom webinar. Panicking, dialing in.
We all know. Yeah, welcome.
Sure. No, thank you very much. It's a pleasure to talk to you. Technical difficulties aside, the joys of online learning and interacting. But I'm glad to be here, and I'd like to thank James and Rebecca for organising this and for the invitation. Nice to see you people online. Okay, so yeah, it's a pleasure to talk to you. And actually, Mike's presentation served as a nice segue into what I'm going to be talking about today, which is strategies and techniques aimed at maximizing high-level performance. And this can range from a number of contexts, whether you're operating in an educational context, or in a sport or athletic context, whether you're writing some sort of test or exam, or whether you're performing some sort of task that requires intricate techniques, body movements, such as when you're performing surgery. Now, full disclosure, I know very little about surgery. I know enough, perhaps, to demonstrate how the kinds of things that I am an expert in, which is psychological theories applied to understanding people's behavior, has relevance. So what I'm going to be talking about today is how psychology has informed maximum performance, and how we can use strategies informed by psychology to maximize optimal performance in numerous contexts. So a lot of my career, I've been focusing on promoting motivation. And maybe some of you are familiar with the TED Talk that James outlined and Tim outlined earlier. And I've also written and authored books on the topic of sport and exercise psychology. I'm a social and health psychologist by trade. So I know, and I've explored how to try to identify strategies and techniques that are optimally effective in promoting people's motivation, so they perform optimally and consistently when they're needed. So what I tend to look at are the different kinds of strategies that have been used and demonstrated to be effective in changing people's behavior. And at the end of the day, promoting optimal performance requires some level of behavior change. And this is a basic model that I've outlined here that identifies the pathways, a model, if you like, how the kinds of strategies that we might use, and I'll outline earlier, can help change people's behavior by changing the kinds of psychological factors that we know are reliably related to people's behavior. And if we can evoke some sort of behavior change, we should get some sort of concomitant change in people's performance. So when we talk about strategies, there are numerous strategies that have been identified in the research literature and by psychologists working in the field, and those who are practicing in the field. Those are the people who have put them into practice and who have demonstrated their efficacy, that are optimally effective in changing people's behavior and promoting high-level performance. Now, many of these strategies and techniques are informed by psychological theory, and there is evidence to support their efficacy. And I'll give you some examples of that as we go along. Now, the main thing to highlight is that these strategies have been shown to be effective for most people and in most contexts and for most arenas of performance. They may not work for some individuals, but generally these are the kinds of strategies that are shown to be effective. So, and many of them you'll be sort of familiar generally with these kinds of things. So goal setting. So setting optimal goals, and we'll take a look at that in more detail a bit later, is a key way to enhance people's motivation. It gives you a rationale or reason for doing the kinds of things that you're doing. So what are the kinds of outcomes that do you want to achieve? And so each strategy has a function, and the function of goal setting, of course, is to evoke motivation. Within that, it's also really important, the second or third point along, it's really important to provide optimal opportunities for people to practice. And actually, I mean, of course, people who practice surgeries are experts in what they do. But it's also important to ensure that you've managed to prepare optimally and prepare for successful performance prior to conducting particularly surgeries or any action that is relative new or novel. Successful practice gives you confidence, and that will promote effective performance. Other strategies are things like planning. That seems like something that's quite obvious, but if you've done something quite a lot on numerous occasions, there is a tendency to become somewhat complacent. So actually planning exactly what you've got to do and having a clear roster of the kinds of actions that you need, that are necessary to be effective, is absolutely essential. And the psychologists have demonstrated that if you write those plans down, they become more effective because it has the effect of making them more concrete, making them more clear, rather than having them as abstract plans that you might have in your head. And they're all about sort of how you might get to your goals. Other things that people have used in the past are things like pre-performance routines. And those pre-performance routines are the kinds of things that you might do to get yourself ready for your performance. Athletes use this all of the time. You may see examples of athletes. They do the same things prior to an event, whether that's walking onto the pitch, whether that's the pre-race or pre-event meal, whether that's the kinds of things that they do, the equipment that they get together and so forth before they line up on a track. Those kinds of things are essential to get a person into the right psychological state so that they perform optimally. And again, successful practice, as I mentioned earlier, gives people confidence. And we see this time and time again in psychology and in the psychology of performance. People who are confident are far more effective in attaining their goals and in performing optimally. And successful practice, knowing that you're able to do something, gives you confidence in order to perform optimally. And then there are some techniques which provide you with the optimal state of mind prior to performance. And those are things like not only goal setting, but those routines. And then there are techniques which have been used fairly regularly, but perhaps not as often in everyday life. And these are things like imagery and cue identification and training. Now, imagery is very much about imagining or visualizing, giving yourself a model of how you may perform the kinds of behaviors and techniques that you're aiming to do in order to achieve your goals. And so imagery is very much about visualizing optimal performance. And they not only provide you with preparation for performance, but they also provide you with confidence. One of the things that often gets in the way of optimal performance is lack of attention and failing to attend to the kinds of things that are needed in order to perform optimally. So basically getting distracted. So one of the reasons why people get distracted and performance drops during the course of an event, for example, is that the kinds of cues that line up the behaviors, the kinds of environmental triggers that line up the behaviors that you're performing, you get distracted from those, or you're not fully attending to them. And so identifying the kinds of cues and training that is extremely important. And actually being aware, cognizant of the kinds of cues that line up optimal behavior are really important. Other things that people might use are things like mantras and self-talk. And again, like cue identification, those mantras and self-talk, they are basically words that enable you to get yourself in the right frame of mind. And you'll see athletes do this all the time. So athletes is a good arena as an example of a performance arena where people who are trying to perform optimally use mantras or these self-talk to try and get them back and to attend to the right cues to line up performance. And you'll see this all the time. Tennis players are very good examples of this. So they're always shouting themselves, talking to themselves, trying to get them to focus on the kinds of things that will signal an optimal performance and also how to respond accordingly. So for example, when they're receiving a serve from their opponent, they need to attend to certain cues. For example, where their opponent is placing the ball, where they're standing on the court, and so forth. And then finally, one of the key issues that people who are trying to perform optimally in highly stressful situations experience is anxiety, and being able to manage that, because our anxiety is the ultimate distractor. People become flustered and concerned when things don't go according to plan, or when they feel that they don't have the resources to be able to manage a certain situation. Then that is the ultimate distraction for optimal performance. So managing those is extremely important. So these are the kinds of strategies that have been identified and been used to try to maximize performance. And they can be used with anybody working at any level where performance is relevant. So I'll just go into some of those, some selected strategies, and give you some examples. So one of the classic strategies is this sort of goal setting approach. And many of you will be familiar with this. This is pervasive across performance contexts, particularly in the areas of education, sport, and in business. And so the idea is that goals need to have certain features in order for them to be optimally to promote optimal performance and to get you sufficiently motivated. And if you think to yourself, well, how often do I reflect on the goals that I have and really think about the kinds of things that really get me motivated? That's not often. Very seldom do people formally think about the kinds of goals that they want to achieve. People are often very much focused on, serial processing of tasks, the tasks that they have to do in each day. And so actually reflecting on the goals and making sure that they have these different aspects to them, that they're specific, that they are measurable, that they're realistic, but they're also somewhat challenging. And also when you're going to be able to achieve them, that will motivate people toward the kinds of things, to achieve the kinds of things. And they can be short-term and long-term. So when you're entering into a theatre for surgery, you need to understand, you need to think about and reflect on the kinds of goals that you might be performing, that might want to achieve, as well as long-term goals in terms of, for example, improving your skill set, and engaging in more challenging, novel aspects of surgery. And there's clear evidence that goal setting works in different domains. This is from a meta-analysis conducted by some colleagues in Manchester, and demonstrating that in various domains, goal setting is extremely important to improving performance. And specific goals compared to no goals or just do your best goals seem to be much more effective, and particularly if they are difficult or challenging for you, for your level. And so ways of prompting goal setting that sports psychologists and performance psychologists use are things like using these kinds of worksheets. And there are a number of different kind of strategies or approaches to this. And I'd be more than happy to share those with you. Another technique that has been used consistently, and one that I've used a number of times over the course of my career, is imagery, both for myself in terms of my own performance, but also in terms of me assisting others to change their behavior. And it's extremely effective and established. It has a long history of being used in lots of different areas, such as in occupational settings, in sports settings, and so forth. And basically, imagery is about imagining or mentally rehearsing performing a future desired behavior. And as I outlined before, it is really about promoting confidence, promoting a sense that you are able to perform the task. And effectively, the reason why is it provides you with a self-model. And this goes all the way back to the work that Albert Bandura and various others working in motivation and social cognition were looking at in terms of promoting better performance. There are a number of different types of imagery. I won't go into those in any detail here. But one example is the so-called process mental simulation, which is where people are prompted to imagine successfully performing a particular behavior. And here's a script from a mental simulation. So it talks about the kinds of steps, imagining the kinds of steps you would need to in order to perform optimally. And imagery works. So here's a meta-analysis that my colleague Dominic Conroy and I conducted, looking at imagery interventions in a health behavior context. But again, this can be applicable to multiple contexts. And we demonstrated that the use of imagery interventions is extremely effective and changes people's performance of health behaviors by changing their confidence or their self-efficacy. And they tend to be more effective when you provide clear instructions, and they work for people who have got more experience, and if the interventions are a longer duration. So a demonstration there, evidence across lots of studies that these kinds of imagery interventions are effective. And they are effective by changing things like self-efficacy, getting people to be more effective at regulating their emotions. People are less anxious if they have imagined themselves performing the behavior successfully. And they also help attention by getting people to attend to the kinds of cues that they need to. And that goes back again to that sort of process model that I outlined earlier. One final thing that I want to talk about is this idea of pre-performance routines. Now, I mentioned this earlier. This is pictures of Blanka Vlasic, and she's former world champion high jumper and is a multiple Olympic medalist in the high jump. And one of the things that struck me about her performance, and this is not just confined to her, this is true also for many athletes, is how very regimented her pre-performance routine is just prior to performing the high jump. There is a clear ritual in terms of the movements that she makes, in terms of the kinds of things she's focusing on. So she peruses, she looks at the scene, she looks at the bar, she checks all of the kinds of things that are necessary in order for her to perform well. So where she's standing, the number of steps that's required to take in order before she takes off, and so on. All of that is extremely routinized, and gets her both into the frame of mind, but also gets her to attend to the kinds of cues that are necessary to perform optimally. So developing pre-performance routines and practicing them on numerous occasions prior to the actual performance is extremely effective in promoting optimal performance. So I hope that has given you a kind of flavor of the approaches that psychologists have used to try and promote optimal performance, and also an insight into the kinds of evidence that has been generated from the psychological study of these kinds of strategies in situ. I'm more than happy to field questions, and I want to thank you very much for the invitation and for listening. And I'm more than happy also to share the various materials that I have in order to promote effective performance using these kinds of techniques. So thank you.
Martin, thank you very much. That's a fascinating run through of a very, very complex subject, and we appreciate your being willing to sort of sit in the hot seat and take some of these, because there's some immediate sort of feedback. I think we're going to have questions afterwards, so we are going to want to go on to one particular group that have been studying performance anxiety, but. And there's various things to particularly run through my mind. Pre-performance routines. We have very long, complex things. We've all seen Rafael Nadal do his sort of twitch before he serves, and somebody before a high jump. That's a single performance and a single event. So hopefully you could be thinking about what it's like to prepare for something that's a free flap reconstruction that takes 5 or 6 hours, when all the crises are going to happen sporadically through that time. So. Anyway, that's over to you. I'm going to ask if we can just move on for the time being to Rob Miller and Matt Hotton, our local guys. Rob is a plastic surgeon at St George's in London, and Matt Hotton is a clinical psychologist who I've worked with in Oxford for quite a period of time, and they've both done quite a lot of work on. Together with James, on performance anxiety in surgery and well-being, and how we can actually really suffer from our performance. Actually, is it measurable, and what can we look at? So I'm going to hand straight over to Matt and Rob, if they could get on screen. I'm not in control of the screens, but over we go. So I look forward to hearing, and we'll have a good discussion after this. Thanks.
Thanks very much, Tim. Just checking, James, can you see my slides? Perfect. So good afternoon, everyone. It's a pleasure to be here and to be given the opportunity to present some of our work in this symposium. I'll be presenting alongside Matt Hotton, who's a friend and a colleague, and as Tim was saying, a clinical psychologist within the John Radcliffe Hospital in Oxford, and I work in London. We hope you enjoy this talk. So what we're going to talk about specifically is surgical performance anxiety. And we'd like to discuss why that's relevant to surgeons, what we know about it, and explore your thoughts and experiences of this, and then be able to offer you some techniques to help manage this. And so this talk's going to be split between myself and then Matt will take over. So we've been presenting on this topic within a surgical context now for a few years. And every time we present, we get excellent engagement and insights from the audience. And so please do get in touch or share your questions in the chat. However, it's also interesting to note that not everyone feels that this topic warrants attention. And I remember the first time I presented this, there was a senior surgical professor in the audience who said, surely if people experience this, then they're in the wrong job. Well, we hope by the end of this talk and also with the preceding talks that you will disagree with this. But whatever your thoughts are, we would like to hear them. So if you look at these three images, what do they all have in common? On the left, you've got Rashford taking a penalty in the Euro finals against Italy. In the middle, you've got a British trumpet artist, Alison Balson, performing a concerto. And then on the right, you've got a plastic surgeon performing microsurgery. Now, as we've heard already, there are transferable lessons from other specialties. And we know that from music, a survey of 56 orchestras showed that 70% of musicians experienced anxiety excessive enough to impair performance. And a meta-analysis within the sports literature showed that there was a significant association between greater levels of anxiety and poor performance. So looking at these together, we know that they all have a technical knowledge and skill base. They utilize skills to perform in front of an audience, and they perform under pressure with their actions having consequences. And importantly, also, they're all elite performers. But despite this, until recently, there's been a limited interest or research into performance anxiety in a surgical context. So how we see surgical performance anxiety, this is our definition. So a state of anxiety in response to perceived negative evaluation by others concerning the performance of a surgical task. And with this in mind, I'd like you all to take a moment to reflect on your own experiences. So our research into this topic started from witnessing colleagues experiencing and displaying profound surgical performance anxiety. There was an operation that was being performed by a senior surgeon, the same operation, but the difference was there was a new member in the team, a visiting surgeon, observing them, and they were unable to perform that operation as they normally would. And then we've spoken to various people, overheard coffee room conversations about people describing performance anxiety, but not really knowing what it was and not knowing what to do about it. So I wonder if there are any specific people you find it hard to operate in front of, or scenarios or operations which you find provoke anxiety? Or have you ever witnessed a colleague struggle to perform an operation when they know they're being observed? And has anyone told you about an operation where they're being watched by a colleague and they know they're not able to perform well, they're performing badly, but they know they can perform the operation? How many times have you heard people say, oh, well, if my consultant just wasn't in the room, it would have all been kind of, I could perform better. So what do we know about it? We performed a cross-sectional mixed method study of UK surgeons, and we found that 87% of surgeons experienced surgical performance anxiety. It may negatively impact their surgical performance, and it negatively impacts their well-being. And that was an interesting secondary finding of this, that surgeons experiencing surgical performance anxiety had a significantly worse well-being score than those who didn't. And also, slightly on a tangent here, but surgeons had a worse wellbeing score than the general population, and female surgeons had a worse wellbeing score than male surgeons. Now, in the circles on this slide, I've highlighted some key themes from our analysis regarding triggers, coping techniques, and suggested interventions. And Matt's going to discuss some individual coping techniques which we've found from doing this study. But I wanted to highlight a few areas within the suggested interventions, which are a supportive environment and acknowledgement of surgical performance anxiety. And a quote that caught my eye when we were analysing this was from a consultant general surgeon who said, "I wish we talked about it more. I wish we shared our insecurities. Most of my colleagues pretend they are living gods." Now, with this in mind, it's great that this symposium is including an entire section on elite performance. We're taught how to suture from day one, but yet no one really teaches us how to be able to optimize our performance within an operating room setting. And And it's great to hear from Martin how the other fields look at this and how anxiety is seen as a key distractor, and yet no one had ever told me that I may feel anxious going into an operation and what I could do about it. So we hope to give you some suggestions and then discuss that. The other thing which is important to note is that there can be potential positives from experiencing anxiety. That relationship we haven't been able to pick apart yet. Is it a bell-shaped curve? Is there a tipping point? But it may be that a level of anxiety increases our physiological and cognitive arousal and improves our ability to perform. And with that in mind, I found it helpful when I've been with juniors who are experiencing performance anxiety, and they say, I feel really anxious and nervous. But therefore looking at that in a positive light to say, well, that's your body preparing yourself to perform to the best of your ability, rather than seeing that as a negative reaction to what we're going through. So at this point, I'd like to pass you on to Matt. So I'm just going to stop sharing my screen and allow him to take over.
Thank you, Rob. Can I just double check that my screen is showing?
Yeah.
Great, thank you. Okay. Fantastic. So as Rob said, I'm going to be talking about what we know about what causes surgical performance anxiety to occur, what keeps anxiety going, and perhaps most importantly, what we can actually do to manage it. Through our survey and through interpreting the findings of our survey, we can look back at the results and we've thought about it through what we would describe as a cognitive behavioural lens. And this has allowed us to produce hopefully a simple model for understanding surgical performance anxiety. We know from wider anxiety research that some people may be more predisposed than others to experience anxiety. And in the context of performance anxiety, the factors which may influence this, among other things, are difficult previous experiences in theatre, certain team factors, the individual's level of surgical experience, and perhaps their own psychological factors and their own resilience. However, anxiety rarely occurs in isolation, and there are typically identifiable triggers. So our research into surgical performance anxiety has shown that this can be divided into technical triggers, such as having to perform a particularly tricky procedure, environmental pressures, such as the time available to the surgeon or how many distractions there are in theatre, and the more non-technical triggers, and that might be things such as the audience, for example, if there is a particularly intimidating colleague in the room. And these factors can lead to the onset of surgical performance anxiety, which we believe is maintained by the interaction between thoughts, physiological symptoms, and behaviour, just as any other form of anxiety. And typically, performance anxiety leads a surgeon to shift their attention inwards in a process which we sometimes call kind of processing the self as a social object. Effectively, the surgeon can become preoccupied with their own performance and how they're perceived by observers or others, as well as being preoccupied by their own bodily symptoms. And that can happen to such an extent that their attention shifts inwards, away from the task at hand. And anxiety is often also characterized by worry before and during surgery, as well as rumination or dwelling on the negatives afterwards. And these cognitive factors can be associated with physiological changes, such as a racing heart, sweating, and perhaps most threatening to a surgeon, having shaking limbs. And not only do these physiological changes lead to an increase in the cognitive symptoms, which I've already described, they also represent a fight, flight, or freeze response, which has many unintended behavioural consequences. And at its most extreme, a surgeon may attempt to avoid certain procedures altogether. They might seek an unhelpful level of reassurance from colleagues, or they might take the kind of the pre-performance routine and ritual that Martin described to an extreme, in which they incorrectly believe that those certain patterns of behaviour are crucial to stop some sort of catastrophic outcome from occurring. And if they're unable to engage in those rituals or have, for example, a specific item or listen to a certain piece of music, actually, if those things are unavailable to them, that can be very overwhelming if they rely so heavily on those things. So it feels really important to us to equip trainee surgeons in particular with the skills to manage anxiety. Our research showed that actually anxiety reduces typically with increased years of clinical experience, but actually we feel like we have an opportunity to try and speed up this process, and which we hopefully will ultimately improve the well-being of surgeons and potentially improve surgical outcomes. So, well, what can we do to manage anxiety? Rather than speaking as a clinical psychologist and listing all the things that I, as a clinical psychologist, might do to help treat anxiety that somebody else is experiencing, we actually thought it'd be more interesting to look at the techniques which the surgeons themselves in our survey said that they had already used before, or they already used, before surgery, the ones they've used kind of during surgery, and the ones that they might use after surgery as well, which are kind of illustrated on the screen. So in terms of cognitive techniques, lots of surgeons engaged in mindfulness meditation, which may have contributed to their ability to be able to shut out distractions, or rather be in the present moment, focusing primarily on the patient. Other people used positive self-statements, which again is similar to as outlined by Martin in the wider performance field, or acceptance techniques. Interestingly, also the elements of planning and preparation would also include things like mental rehearsal and imagery, visualization. Again, things that, as Martin outlined, are found in other areas of elite performance. And other people reported after the event being able to reflect on the consequences or the outcome of surgery, but in a positive and productive, reflective way rather than a ruminatory way. In terms of the physiological techniques people use, well, lots of surgeons reported ways of managing the physiological symptoms of anxiety. Many use relaxation techniques. I think out of those people who experience performance anxiety currently, 45% of people had at least one technique that they used to manage anxiety, and exactly 50% of them felt that they were effective nearly all the time. So some of the relaxation techniques were things like breathing exercises, progressive muscle relaxation, and again, visualization and imagery, as discussed, kind of comes up again. I guess, although they're cognitive strategies, they often have physiological consequences. Other people, although a much smaller number, reported using medication. And as mentioned just before, lots of surgeons reported meditating or using mindfulness techniques. And although the primary aim of these techniques or approaches is not typically to produce a physiological change or induce a relaxed state, this is often a pleasant and helpful secondary consequence. And finally, in terms of the behavioural techniques that surgeons outlined, some surgeons described avoiding certain procedures, which in the short term can certainly reduce anxiety. It's very effective at that. But in the longer term, avoidance can prevent skill development, can also prevent the surgeon or a surgeon from learning to cope with anxiety. Surgeons, in a more helpful way, described finding routines and as Martin said, those kind of pre-performance routines helpful. And again, some of that included practice, mental rehearsal. And finally, talking to colleagues and having formal debriefs were also found to be helpful. So just to wrap things up, in summary, our research has shown that surgical performance anxiety is a real phenomenon which is experienced by a huge number of surgeons. It requires close attention. We're not saying it's necessarily a positive thing. We're not necessarily saying it's always a negative thing, but it certainly warrants further investigation. We hope that today's presentation and our research will just help to open up a wider conversation on this topic, which will hopefully not only impact on the well-being of you as surgeons, but ultimately improve patient care. Thank you.
Matt, thanks very much. Am I live? I hope I am. Yeah. Okay. Great. That's brilliant. Fascinating discussion, and your work has obviously got lots. There's lots of mileage in it to look at in the future. We're going to. We really want to just open up some of these areas, and I want to go back to Martin. With a couple of questions that you've probably seen on the screen, and they're really slightly related, Martin, to your concepts. You were presenting some ways of managing stressful events that athletes use, and you've talked about pre-performance routines and imagery, those two things together. And our questioners have asked some similar comments. The strategies pre-performance routines from David Azadi, this is, you suggest the best use for elective surgeries. Are these techniques as effective to trauma surgeries, which are less predictable? And rather similar, actually, Dan Markson says, thanks for a fascinating talk and insight into the psychology of optimizing performance. Can you give any examples of how imagery might help us in surgery? And then he presents this rather funny scenario of slow clapping before people get into theatre and getting the whole team to start until we start. How relevant and is do you think are pre-performance routines and even imagery and imagining things suitable for long, complex operations when there are many more unpredictables than, in my words, the tennis serve and the high jump, which is a one-off thing. They've got to get into the zone and do it. But we're not. So over to you. Can you answer some of those queries that people have thrown up?
Yeah, sure. No. I think those kinds of strategies have been used regardless of the duration of the performance that's required, and so there is sort of fairly good evidence that those routines are important, and you need to get yourself into the frame of mind that's necessary to initiate the task. And oftentimes, if people are experts, what they need to do is get over that initial hump of the anxiety that's often, when you're confronted with when you're first starting. And actually, you realize that after you get into the performance, there is an element of flow, and you actually find yourself working fairly consistently. So you need to get yourself into that frame of mind before you initiate the performance. And so a pre-performance routine, doing the similar things and making sure that everything is prepared and having a plan to do that is extremely important. And there's good evidence to support that, regardless of whether it's a relatively brief period of performance or whether it's a long-term performance. But as Matt and Rob illustrated in their talk, it's also important that you're able to maintain your focus during the course of the task at hand. And if you're doing a long surgery, something that requires a long period of time, extended period of time, being able to identify the times and the situation. Well, first of all, you've got to avoid distractions, because those distractions will take you away from the task at hand. But one of the key things or the key issues is that actually people don't realize that they're getting distracted. They don't realize that their concentration is wavering. And so identifying, being aware of that, and then trying to come up with strategies to bring yourself to be more focused is extremely important during the course of the surgery or during the course of the performance. And often you see this in sport. Often you see that if you're looking, tennis is a good example. A player's concentration drops, their performance drops, and you see quite clear drop-offs in performance. And often the player is not aware of the fact that they've been distracted from whatever, whether it's the crowd or whether it's something that happened earlier that was negative, and they're lingering on that. And the presentation that we just had says that, illustrated that your concentration can waver. So identifying, things like talking to yourself, identifying strategies that could signal, when is it that I get distracted, is really important, and trying to come up with strategies to do that and plan for those. So those can be incorporated in your pre-performance routine, such as visualizing or imaging those kinds of situations. So if you imagine the kinds of situations, okay, when is it that I might get distracted? Whatever it is in the theater or in the situation that gets you distracted, to try and identify those situations, get aware of them, become aware of them, and try and identify a way to kind of bring yourself back, whether that's a mantra or a word like just, concentrate, focus. It could be as simple as that.
Martin, that's really, really thoughtful. And really good tips. I wonder if I can bring Mike Tyler in actually a little bit on looking back to some of the sort of mantras. And I wonder whether our surgical checklist that we do before operations is similar to a skipper's pre-sailing check before he goes off on the fastnet race. Or something like that, but then he's dealing with problems, and we've got a very good question from Vimal Gokani about in surgery. They're often he's talking about how systems can break, but much of the adversity we place is down to issues on the day. Often a new staff member, a bit of kit not working, working with somebody in a different specialty. Absolutely right, and he's got his finger on a button. That's a really important question that it's dealing with the stuff that the grit in the oil, in a sense. So I wonder if Mike as well could comment, as well as you, Martin. Mike, would you like to?
I think it is similar to some degree. I don't think the Who is necessarily similar to the Capstone, but I think it's really important that if you are the consultant running the show, that you take on the responsibility, and I think you can do lots to the other people. So firstly, I have a little routine. If I'm doing a free flap, I don't answer any emails. I go and sit, and I have from a plastic cup, because then the cups get rather nasty, instant coffee, with a bit of milk in, and I sit and I just kind of zone out. So it's very interesting, because I'm doing these things that Martin talks about. There's a little bit of mindfulness, and I zone out, and I can chat about something, but if somebody asks me a divisional question, I can't concentrate because I'm zoning in. And I think the other thing, and my answer to the question from Vimal is, I think the big danger with all of these sort of equipment's not working is time. And what you have to do, and I've worked with some bosses, I think, your colleague, Tim Henkiel, is very good at this. What these things do, they say they can't get the equipment, they then put you under time pressure. And time pressure is this huge distraction. Oh my gosh, we're not going to finish the list in time and everything. And I think time is one of our biggest enemies. As surgeons, we're always under stress. So we've got to axe time. Time doesn't matter. So when you have that little coffee before you go into theatre, time is stopped. And you go into theatre, you can handle that problem. Fine. You don't have that equipment, can we get the old one? If not, can we, there's always a solution. But what puts you under stress is when, oh my gosh, we can't get it by 2 o'clock, etc., etc. So get time out of there. Just say, look, I can handle this new time. And it is that zoning in on the job in hand, and that sets the tone. And a really good skipper in the fastnet sets the tone. When all hell's breaking loose and the sails are flapping, the good skipper that is not phased by it the slightest, everybody else relaxes. No, it's not a problem. We'll just take the main down. We'll do this. We'll jump into the life raft. It's not a problem. That's fine. Once the skipper starts to go a bit, oh my gosh, Yeah. Anyway, those are my comments on that. Thank you.
Fantastic piece of advice, Mike, from experience there. And I think that's exceptionally good. Peter Budney has made a comment here that even in the long ops and the urgent ones, we generally know from experience or prior learning which elements are going to be the complex or triggering points, which are then the ones to focus on. And I think that's very good, very good advice from Peter there. Does anybody else have comments that they want to maintain, that they want to throw in? I'm intrigued about the whole ability. James, I think you put your hand up, but the whole business of imagery, actually imagining things, actually ran through my mind. I wonder if we could, to change healthcare behaviour at the moment, we could get people, we need a national campaign of imagining you're going to be vaccinated, which would do people a lot of good, actually, to get in the zone. James, you've put your hand up.
Yeah, just a couple of comments, really. First of all, I wonder, this is directed at Martin, about the types of personalities, whether there are certain personality types that make you better at dealing with these stresses. Certainly in the work that Matt and Rob, and also actually Tim was part of our study group, what we found was that people who had high perfectionism scores were much more prone to surgical performance anxiety. And the second question, which is really directed at Matt, is to, because Matt works with doctors all the time, is whether actually, much like our the musicians and the athletes, whether we should really have psychologists as part of the team for the surgeons.
Okay, good, great questions. Martin, would you like to come in on that, or Matt first?
Sure. No, those are extremely important questions, and the comment on perfectionism is very pertinent. One of the things that has been demonstrated fairly consistently is that there are people who, you do, if you think of in your head of the archetypal cool customer, people who keep a cool head even when things seem to be going awry, there are some personality traits that may determine whether a person responds in a more flustered, anxious way or in a more cool, collected way. in certain situations. And so there is a construct that personality psychologists study all the time, which is trait anxiety, which is basically your tendency to be more anxious in certain situations. And so, yeah, there is an effect of these kinds of individual differences or personality, these traits, on people's performance. But they tend to be relatively small, or the effect sizes tend to be relatively small against the sort of situational factors that are likely to determine somebody's behavior in certain situations. So if you are someone who is well prepared, even though you may have high trait anxiety, you are much more likely to perform well. And this goes back to what Matt and Rob were saying and Mike was intimating. It's a lot of it is about preparation, preparing optimally. And those pre-performance routines are the kinds of things that are important. But also, you know, how do you keep a cool head when something goes wrong, when something happens and it's kind of like, whoa, I didn't foresee this. Actually, the key strategy is to foresee them. So to try to have before your event, what kinds of things do I need to put in place in case these kinds of things happen? And this is where your expertise as surgeons come in. If you are an expert in a certain area, you can think of the kinds of things that could potentially go wrong. And I think, is it you, Tim, or Mike mentioned it? So, mentioned a situation that I thought that would be horrendous if suddenly there was sort of blood spurting everywhere in a surgery situation, and that is clearly something that you can foresee because you've had experience with that. And often we see the people who do have cool heads under high pressure situations, or when something goes wrong, are people who have experience with these kinds of situations and have been successful in dealing with them in the past. So I think one of the key things is to anticipate those kinds of eventualities. And if that happened, what would I do? And one of the ways to do that is just to imagine it, is to think of it almost in real time in your head. What would I do? What would other people around me probably do? Would they panic? And if so, what would I need to do? What would I need to say to them in order to calm them down? What are the actions, as probably someone who's the leader in that situation, what are the actions that I would need to do to convey calmness, but also to get the situation under control? So those are the kinds of things that you can easily imagine prior to performing. And I think this is one of the reasons why, in that meta-analysis that I mentioned earlier, one of the reasons why we find that older people are much more effective in using imagery and using it successfully is because they have experience. They've got experience in coping with those kinds of eventualities. Not all of them, of course, but having similar eventualities happen enables you to be more effective in anticipating, imagining, and therefore dealing with, when they come to light, these kinds of eventualities.
And if I can just add one thing, because the one thing that I've been in that situation a couple of times, and as I said, it's a bit like going overboard. There is this obligatory panic response that your body has when the blood suddenly spurts up, and even though you've been there before, you cannot stop it. You cannot stop your heart suddenly going from 70 to 150, boom, 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 boom. And I have to say, what I've learned to do is, you just put a stop on it. You do something that just, I close my eyes, and you've got to give yourself 40 seconds to just allow that if you try and do something there and then, you're not in a capable state. You're overwhelmed with you're going to do the wrong thing. Just close your eyes, allow your heart rate to go back down, and then you start make those sensible decisions. Right, what I need to do now is this, and this, and that. But jumping in straight away, and it's the same as I said, when you're man overboard, there is an obligatory panic response. You cannot stop. So let it pass, and then you can start to make some sensible decisions. That's my advice to any young people out there.
Great advice, Mike. And the play for time moment, I think all of us experienced people know we've done that in certain respects. We've come pretty much to the end of our time. We haven't given Matt a chance for perhaps a one-line answer to your question, Matt. And there's a very quick question from Kaneka Bernard about any suggestions to how a junior surgeon might support senior colleagues who note having performance anxiety. It happens to us all. We all have bad times and sometimes imposter syndrome we could have got onto actually, but no time. But Matt, a quick one-liner to answer the question.
Yeah, so in response to James asking about the role of psychologists in supporting surgeons, I think effectively we do need to learn from other elite performers. I think the positive take home is it's happening, it's slowly happening. I think COVID-19 has been a real catalyst for identifying the wellbeing needs of medical staff, surgical staff, all healthcare staff. So I now chair a network in the Association for Clinical Psychologists of over 150 clinical psychologists working in staff support. So now more and more clinical psychologists are working specifically to support staff groups, mainly medical, surgical groups, to manage their own well-being. I think within that, what we really need to be building, I think, is kind of drawing on our clinical expertise, both in terms of managing psychological distress, but also our academic psychology knowledge around performance, and meeting the two in the middle and using that to support our colleagues to both optimize their well-being, but hopefully then also optimize their performance.
That's brilliant. Thank you, Matt. And I just want to stress actually that I put in a plug for the College of Surgeons of England that have a huge focus generating at the moment on the well-being of surgeons generally. The whole business of surgical well-being, it hasn't been focused on enough in the past, and there's a big shift of emphasis led by people like you and the group that you've been working with. So thank you for that. And I think if nobody has any other comments to add, we can always put things in the chat box, but I do want to thank all of you who've presented, and Martin particularly for coming in from California, where it's probably about 8 in the morning or less than that, I suspect. Thank you for joining us. Oh, was that 7? Yeah, 7. Okay. Thanks. Go and have a really great California coffee. And thank you, Matt and Rob, for your presentation and for inviting us. So we'll I think with that, move back to James and Shirley and Rebecca to hand over to you. So thanks very much.
Thank you, Tim, and thank you to all our panellists. Amazing discussion. We're way behind because we've run over by 20 minutes, but I do think these are really important things of which traditionally we've had no teaching or training, and I'm sure more emphasis on this is going to be extremely helpful for the future of our specialty. So now that we've heard about the theories involved in achieving and maintaining elite performance, let's see this in action at one of the premier units in India. Ganga Hospital. My first impression of Ganga as a fellow on day number 1 was seeing a successful arm replant done by Harry Venkatramani, who's going to speak to us shortly, on day 1 of my fellowship. So James is going to just introduce the hosts.
That's great. So thanks very much. So this session will be chaired by Prashant Govilkar, you can see there on the screen now, one of our senior consultants here at Stoke Mandeville, and also Jeremy Rodrigues, another consultant, hello Jeremy, here at Stoke Mandeville, and also associate professor at the University of Warwick. So I'll leave it to you guys to chair that session. Thank you.
Thank you, James. We are now moving on to our second session, which basically covers the topics of trauma and brachial plexus injuries. We've got 2 talks in this session, and the plan would be to take questions in relation to these talks at the end of both the lectures. We've got 2 excellent speakers, both of whom are prolific contributors to the field of microsurgery and brachial plexus surgery. Both come from the prestigious Ganga Hospital in Coimbatore in South India. So we've got Dr. Raja Sabapathy, and we've got Dr. Hari Venkatramani. Welcome to you both. So the first lecture will be by Dr. Raja Sabapathy. It gives me great pleasure and pride to introduce Dr. Raja Sabapathy. Raja started his medical education and graduated from Stanley Medical College in Madras, now known as Chennai in South India. He trained in plastic surgery in Chennai and then had a short stint, I think it was in 87, 88, here at Stoke Mandeville Hospital as a fellow, and then did his microsurgical training at the Canisburn Hospital in Glasgow and the Kleinert Institute in Louisville, Kentucky. He then returned to India and with his brother, who is an orthopedic surgeon, started or developed the plastic and orthopedic departments at the Ganga Hospital in Coimbatore, South India. Over the years and with his excellent efforts, Ganga Hospital has revolutionized management of major trauma care in India, and has firmly put India onto the international microsurgery map. Always keen on teaching and training, Raja set up the Bruce Bailey Fellowship, which is an international microsurgery fellowship, which is today one of the most sought after microsurgical fellowships internationally. And this is quite a turnaround, because I remember during my training days, we did not have any formal microsurgical training in India, and we had to look to fellowships in the US, in Australia, in the UK, to try and get microsurgical training. So that is one of the finest achievements, I would say, that Raja, you managed to get, other than obviously the other ones that I really cannot list within the short time. Here at my Stoke Mandeville Hospital, we have had a close association with both Raja and with Ganga Hospital. As I mentioned earlier, Raja did spend time as a fellow here at Stoke Mandeville. And then we have two of our current consultants, Shirley and Jeremy Rodrigues, both of whom have done the Bruce Bailey Fellowship. We've also had other trainees, and James Chan as well, spent time at Ganga Hospital gaining microsurgical experience. Raj has been very supportive of the Bucks Hand Symposium and microsurgery symposium that we have arranged. We had one in 2019, and we really hope that we continue with this close association. So over to you, Raja, now. Thank you.
Yeah, thanks, Prashant, and I should thank all the staff at Stoke Mandeville. So thanks so much. Every time it's always a pleasure to get the topic from James. And this time he said he would talk for us about 15 to 20 minutes on the updates and the current perspectives on trauma management. And anytime I get a topic, I always think the words that are in the title. One is update, and that means what we do now in the current state of things. And perspectives, the word perspective is very interesting, because it's a point of view. I think what a particular individual thinks is important, what's not. And I think that's truly personal. So in this talk of about 15-20 minutes, I thought I'd put what do we do now, and what do I think about how trauma care is going. And looking back over the last 30 years, I was in 88, 89, I was in Stoke Mandeville. I very fondly remember that. I'm extremely grateful for what you did to us at that time. And here I am with Mr. Bruce Bailey. And I was looking back the last 30 years, and I found that in the 90s, in the first decade of this century, we found that techniques, a lot of techniques were refined. New innovations became established in clinical practice, like NPWT came in the late 90s. And there were a lot of basic science research led to the development of new flaps, angiosomes, perfosomes, concepts, and advances in immunology led us to do transplants. And so many methods of rehabilitation came up. And I find that all these things are very high impact advances, where they really influence a lot. And I was also thinking, what will happen in the last 10 years, to find out any great impact that has happened and how things are going. I was finding it very hard to identify a particular advance which we could say made a great impact. And the only thing that has made a great impact is in the method of trauma care delivery. I think everywhere, I think every country, I think what mattered was how the known advances were delivered and reaching out, delivering quality. So when that happens, logistics become important. I think, for example, when COVID came, that became much more important. And infrastructure, human resources, and the attitude to work and the development of the attitude, I think they became the prime issues. I shall be putting in 3 patients. I'll be putting in the little major injuries to drive home my points about how the future might be. Say, here is C.H. chap, and I was proximal to shoulder aversion amputation. So almost in the forequarter amputation. So you've got a part of the scapula in the hand. I think the conventional wisdom, I think conventionally said that this is not replantable. But we always ask the question now, what will happen if you don't? And what will happen if you can? I think that's the question. These are the two questions now which you could ask. And whenever you find so much proximal, that means you need to be very fast. And then if you could do it, why not? So the same patient replantation has been done. And we'll put a small framework as to how it was done. So he had come to us after the accident. He traveled about 30 kilometers. 1 hour and 10 minutes. He was in our setup. And the total cold ischemia time has only been 4 hours. The total ischemia is only 5 hours, 10 minutes. And bone fixation has been very short. I think it's only be a clavicle to humerus, a quick short. And we have repaired the two nerves, radial and ulnar nerve been repaired. And the same in future is the part of the rehabilitation. And we really go all out, keeping the muscles alive. So we give a mission and then start doing it. And you find that 1 year, because the radial nerve repaired, he's got a good triceps. I think triceps starts coming. And the ulnar nerve, the ulnar extrinsics, flexors start working. He has got a wrist extensors has come. I think we need to believe, it could happen. So that belief has to be there when you start doing it or when you see him. And then what happens, you use all your hand surgical techniques that you have to make it better. So the triceps to biceps we transfer because we could use the gravity for the triceps. So triceps to biceps transfer so that now he gets this flexion elbow and the wrist is there. And then now the extensive ulnar extension become much more stronger. So you could use the side hitching of the FDP. You could use that for index and middle. And you could transfer the dorsal sensory branch to median nerve to provide sensation. And now you see, so if you see this picture, the last picture, you'll find that the amount of flexion that he could make. You only need to do a claw correction procedure now and then get to the next stage. So we came from this stage to the stage, where it, but it's not new. If you see when the replants were started, they were doing, and a lot of things were told against. And this editorial in 1973, he said, now get in there and replant. And he said, but only nice words there. It places this on a sounder basis. But then what's in bracket is nice. I think when done correctly. So if you do that, it should be fine. And then we just published one of the rare cases of forequarter replantations done in the world. So where is the challenge? I think the challenge is that if you really split it into various components, I think in the previous talks, they said, don't get overwhelmed by the challenge in front of you. If you just calmly sit down and think, okay, what needs to be done? You need to debride, right? You can do that. You need to fit a plate to the clavicle to the humerus as well. You can do that. You repair the axillary artery. You can do that. It's a big vessel. Can do that. And there are two big nerves, and you can do that. So if you split it into various components, I think each part of it is easy. But then the challenge is to all do them all together. I think that's where the challenge is. So once we master that, then what happens is, indications for salvage become extended. I think this is because the possible improvement in function due to secondary procedure, you don't do that because we know the nerve and tendon transfers. And I consider these two things have really revolutionized the way we have extended the indication. The possibility of doing FFMT and toe transfers were really revolutionized. So the quality of reconstruction is also improved. So one, I said the improvement in or extending the indications for salvage, that is extended. And the quality of reconstruction also improved. For example, I'll put in another patient. Say here is the old man in his late 60s, and he comes with a bilateral injury. So this is the right side. So we got a big bone loss there, and there was soft tissue lost. And that's the left side. So his long bones are okay, but the whole of the sole is gone. And being old, and then he's got a lot of comorbid procedures. You don't really need to decide against salvaging this. But then you could really think, okay, how are we going to do this? You are going to amputate, then why not we take the whole sole as a free flap? And so you take the sole as a free flap, and that's the left side as he has come. So there's a sole free flap that's been harvested, and that's before in a post-debride picture, and then we are putting on. But then you need to think when you are switching sides. So what happens is that your medial side becomes the lateral side. So you need to have a long length of a vessel, so that you need to go the other side and then put it on. So that's the way we put it on, and then there's some exposure that comes in, and we do the abductor analysis covering up this thing. So that's the immediate picture, and that's the long-term result. So that's the same old man in his he is not having any sophisticated process. He's having a very, very basic process. But then, if you really see, what he says is that having my nice foot, you see, that's what makes me get a difference. He says that. So if these reconstructions have not been done, I think still nobody would have questioned. I think because now you say, oh, there are bad injuries. It is easy to explain not performing it, and in fact, it's be difficult to explain doing it. And as much as it is not difficult to succeed, so it's only a question of what you need to be done. It needs to be done. So making them possible, we personally feel now, because having heard the lectures in the beginning, it just can't happen by improving the skill levels. I think the skill levels that are needed to do these things exist in very many places, almost all places. But then the only question is required is the intent to act, I think intent to perform, and you need the logistics to support it. I think that's the important part of it. So we found that the outcome determinants is that once the accident happens, they have to come to the right place. The site of reception of the patient, when they reach the hospital, and the senior people who could take the decisions. And the cost of care shouldn't influence the decision, or else you should need to keep the cost of care down. And that's what is very important. So that's what I said is, if the patient who has come with the shoulder level amputation, if he has come about 5 hours later to us, we couldn't have done it. There's no point in we being there, we couldn't have done it. So I personally feel that all of us, in addition to getting better by ourselves, we should also make the society maybe aware of what we do. I find throughout the world right now, in a lot of places around the world, how to go, that's through an ambulance or fly or something like that. Now, how to go has been protocolized. But then still, where to go is not fully clear. I think that the jump, we really need to take. I think that's what take. The next hurdle is that what happens when they reach there, the place. So for the last 30 years, we have been receiving patients just in the room opposite to the operating room, adjacent to the operating room. And it really requires more than 25 years to make it as people accept it. So when they come in, they give a block, it's pain-free, and somebody comes with a big blast injury. There are so many senior people to take it on. And it really, it took us in 2020 only we could publish it. Because so many times it asks the question, is it safe? Is it good? Will it work? So we still took about 27 years to get it. But I am very, very, very convinced that the next jump we could have is, if you could resuscitate major trauma next to the operating room where the best of the talent is there. It available like quick resuscitation, fast decisions. You will have a short arrival to the operating theatre interval. And who sees the patient first matters much to the outcome. And no better thing can we have if we have senior people seeing them. And the next thing is the availability of the operating time. Because you'll see in my talk, I'm just shifting from not that about the techniques. I think techniques is in our control. I think we can do that. But then what we really need to do is to work on this to make it possible. When you plan the trauma centers, the bed to operation theatre ratio must be very small. At Ganga is 16 beds, we have one operating theatre. We have 550 beds now. And we have 36 operation theatres which run at the same time, and 8 operating theatres are available 24 hours. I think that's the key. I think most of the times we find we build big buildings are built, but then the number of operating theatres are very short. And the next thing is the high anesthesiologist surgeon ratio. I think you need to have a high number of anesthesiologists because ultimately an output of a surgeon is directly proportional to the operating time available. We can't work by writing prescriptions. So we need to, so for that, in addition to the OT time, we also need personnel. And when you have a lot of anesthesiologists, I think you also get to make them skilled up in regional blocks because that's safer and also is extremely cost saving. you don't really require so much of staff to monitor a patient who is under a regional block. The last point, in the last 5 minutes, I just want to take about what's the other thing which will make the trauma care jump. There's a collaborative medicine and the increasing in the value of communicating with one another. So these are the times of WhatsApps and digital media. All of us are extremely happy to talk to somebody who is miles and thousands of miles away. But then we shudder to talk to the fellow next door, or shudder to talk to the patient who's in the next room, or people who work with them. So I think that has to improve. If then only results in polytrauma can improve. And for that, you need a leader. The question is, who becomes the leader in a polytrauma team? Either it's the plastic surgery, orthopedics, anesthesia, trauma. I think the list can go on. My take is that anybody who is willing to take decisions and implement them can become the leader. I think that's what and is very important. It's not a guy who take. I think right or wrong, he has to take a decision, and over a period of time, if he continues to take decisions, he'll become good. So, for example, here is a part of a polytrauma. I think this is exactly what is for us. Major hole, a soft tissue, and then it's a bad injury. In addition to that, they got a spine fracture, rib fractures, pneumothorax, sick, peroneal post-vaginal wall injuries, major peroneal injuries, a segmental femur fracture on the left side. And this is ours. This is plastic surgical problem, but then there are a lot of other things in this guy. So which, if in this girl, young girl, and if we don't take care of all this, we can't do anything there. So what really happens is, this way I just put the timeline. ICD inserted, intercostal drain inserted, debridement, fixated, all this done, and a spine fused on the 2 days afterwards, and all of them debrided, all wounds are debrided, but then this done in the colostomy done. And next year you take the long bones, they are all done. And after the long bones, it's still on a ventilator, tracheostomy, and then 18th, we put the last one, we are there, we put an ALT flap to critical raw area, and then finished off. But then it takes about 8 days, but then it's gone on and on and on. But then if you have to make this on and on and on, what needs to be done is that frequently somebody needs to be talking to everybody on and on and on. So I think that's what is very important. So it goes on like this, and that's a girl after colostomy. And there you have a ALT flap, which is to plug in the hole and also to cover. And after that, when you give colostomy, you also had a posterior nerve graft. And there she is, you're not done any further surgery after this. That is all done. And then see the way she walks. And this is possible if only somebody is willing to talk. And everybody who's been involved in that, is willing to talk. And I'm sure that this is a much, much better reconstruction than to have any process. But how does that happen? It happens by continuous talking at the bedside. I think you need to make the rounds. I think it's led by our intensivist, his orthopedic surgeon, the plastic surgeon, other intensivists, a lot of other anesthesiologists, dietitian, everybody over there. I think is there, polytrauma rounds, which we make it. And that has to come from in the very beginning. And people say whether it's okay for our economies, and the cost of care is an important factor in all economies, and every economy is important. And the best way to reduce the cost of care is to actively do things to reduce the complications. I think that will make us all go back to what I spoke in the last 15-20 minutes. What is very important is that you need to see the patients first. I think the senior most people must see it. And beyond skills, I think right now, I think we need to concentrate on the logistics so that we get things that are done at the right time. If you want to make impact, I think it's in addition to improving skill development, we need to concentrate on this. And what is really required right now will be, if you want to improve trauma care, I think what we need is a good leadership in healthcare. So thank you very much for the opportunity to talk to you. Thank you so much.
Thank you so much, Dr. Sabapathy. It's lovely to see you and inspiring as always to hear you talk. And thank you for your time and your generosity today. It's really a phenomenal pleasure to have not just one, but two of the titans from Ganga speaking to us today. And it's a delight to introduce Dr. Harry Venkatramani next to talk to us about brachial plexus, to follow on from such a tour de force on microsurgical reconstruction. Harry is internationally recognized in this field He has been recognized and served on hand and plastics and brachial plexus groups and societies, council members in India, has published 12 book chapters on a range of topics, including this, and over 70 peer-reviewed publications. And I had great pleasure and privilege as the Bruce Bailey Fellow to learn directly from him on the topic of brachial plexus management and assessment during my time in India, which was just absolutely second to none. So Dr. Venkatramani, thank you so much for joining us. The floor is yours and we're really looking forward to it.
Thank you, Jeremy. And it is so nice to see all our friends who have been to Ganga and many times our visits in the UK. So after Dr. Sabapathy, as you said, the tour de force lecture, what I will be speaking in the next 35 to 40 minutes would be our experience in management of adult brachial plexus injury. As you just heard, and you are aware that we are now a 550-bed specialty center, of which annually we do around 10,000 plastic surgery cases. But if you see the number of brachial plexus related surgery we do annually is around 350. My journey also started exactly a decade after Dr. Sabapathy in brachial plexus, when we, along with Dr. Sabapathy, we visited to Professor Panupan in Bangkok at Siri Raj Hospital and Professor David Chuang at Changhung, Taiwan. And then I will be briefly covering all these aspects, which has made brachial plexus care at our center now really good. So what all we have learned in the last 20 years in brachial plexus I would like to summarize in these next 35 to 40 minutes. So first of all, we need to know the anatomy like the back of our hand if you are brachial plexus surgeons. So it is something which has to come instinctively to us. A simple thing, the first question I ask anybody who enters a brachial plexus theater is to draw the plexus. And then most of the time you'll find that they will start drawing, but then when it really gets to specifics, they start faltering. The simple question you need to ask a fellow, what is the root value of median nerve? If we include C5, many textbooks do include, but ideally you need to remember it is C6, C7, C8, and T1. And this one anatomical fact really sort of clarifies the whole thing. If you recollect, no area of the median nerve sensory distribution or any motor distribution comes from C5. So you need to learn how to draw, and this is very important because once you learn this, then you are able to document things better. Now, the other important anatomical fact which we have learned also, and which is very useful to remember, is when we see ruptures and avulsion, we always find the upper roots have more frequent ruptures and the lower root have more frequent avulsion. And this is because the C5, C6, C7 roots are firmly anchored to the respective transverse processes with strong ligaments. And that is what leads to this kind of picture which we normally see. The next thing to remember is that our shoulder joint, these muscles which are powering the shoulder, has got nearly 1/3 of all the fascicles. And the other important thing to also see here is that the radial nerve has got the maximum number of axon count. So the median and the radial are really close to each other. The axonal count of our donors is also very useful to be kept in mind. And if you see, the phrenic nerve ranges from 800 to nearly 1700, and this is a range you need to keep in mind. The superficial sensory nerves, which we did not give very importance in the very beginning, now are very useful for providing sensation in the upper extremity. And also we can use some useful motor nerves also from here. As the plexus starts between the scalene triangle, the only nerve which is important to remember is that it is a phrenic nerve which goes from medial to the lateral to medial, remaining all the other nerves goes medial to lateral. The M formation which can happen at varying levels, but it is important to keep in mind that the musculocutaneous nerve and the median nerve has got very close relationship, and there can be a lot of variations in anatomy. In brachial plexus, variations in anatomy is a norm, and it is to be kept in mind. So these are the various brachial median nerve branching patterns. If you see here, the classical one is they are separate, and the musculocutaneous gives the biceps and the brachialis branch. But then there are a lot of variations. Even in the branching pattern of the biceps motor branch, there are variations. But the most common one is the type 1, where you have a common branch going to both the heads of biceps. But then intraoperatively, you need to dissect and see carefully, because many times you will find if you have a pattern which is something like this, where it is only going to one of the head, the other head may be not innervated. And then these are some of the reasons why we get a suboptimal outcome when we do a nerve transfer. So these are the variations, and we're just in the process of publishing 150 consecutive cases of MCN with the various variations. If you see the different patterns, it can be very close to the median nerve, or the sensory branch can come from the median nerve, or the brachialis branch also sometimes can come from the median nerve. The next thing we have found very useful is to do a good clinical examination. And this book I would recommend to everybody. There's a fantastically written chapter by Professor Aymeric Lim and Sandeep Sebastian from Singapore. What they have said is that instead of going directly jumping to the hand examination, first you start from proximal to distal. In the hand, in the entire upper extremity, we have 70 muscles to be examined. The 70th muscle is actually the diaphragm. So it doesn't as such constitute a muscle of the upper extremity, but that is a 70th muscle. So basically you start with proximal to distal and from the root to the periphery. So if you go there, then you will basically have 13 steps. So you don't miss any muscle on the way. Before we start, you need to have a good clinical assessment of the Horner's sign and the Tinel sign. Two nerves are very important, which is in decision making. One is the long thoracic, which is an indicator of availability of proximal nerve roots. So by looking at the winging of scapula and examining the serratus, we can find this out. The other nerve is the suprascapular nerve. So this is also going to tell us the level of involvement, whether it is distal to the suprascapular or proximal to the suprascapular. Coming to investigation, we do very minimal investigation, but then the 4 things are very useful. The first is getting a plain chest X-ray in deep inspiration to look for the phrenic nerve palsy. As you see here, if the diaphragm is raised 2 intercostal spaces, that means there is a phrenic nerve palsy. Transverse process fracture is also an indicator of nerve injury and many times associated with this. Shoulder girdle X-ray is very important because there is a lot of trauma which happens, and all our nerves, mainly the axillary nerve, the suprascapular nerve, and also the radial nerve get involved in these fractures. We have few interesting cases where we have had malunions. So it is to be kept in mind that if you have a clavicle malunion or a non-union, underlying nerves can get affected. This patient was asymptomatic on arrival, but as the malunion increased in size, it started compressing on the nerve at the level of the cords below. And then we need to excise it and then replate it and free the nerves. MRI, earlier we were not doing very frequently, but now with high resolution and very good machines, we find, and very good interpretation by our radiologists, more accurate information is now available. And many patients, by the time they reach us, they already have a good MRI at hand. So we did a study and found there is good correlation of MRI with intraoperative finding. If you see on the left side picture, the MRI is suggestive of avulsion of the nerve roots. Whereas when you see intraoperatively, they are looking in continuity, but if you give a tug on them, they are loose. So, and preoperative MRI finding of an avulsion and intraoperative finding of lengthened nerve roots, which is not stimulatable, gives a good correlation. And this is to be kept in mind when we do the reconstruction. And now we get pictures like this, which is real high resolution. You can easily make out, and even the radiologist can give a good comment on the level of injury and the extent of injury. Angiogram is another very important investigation. So whenever there is no radial pulse palpable, we always do an angio. And this gives an indication of the level of injury and also subclavian artery or the axillary artery injury, which is closely associated to the plexus. So if you have good anatomical knowledge at this level, because you need to use these branches for a functioning muscle transfer if required in a global palsy. So having a good anatomical knowledge of the branches of the subclavian artery and the angiographic picture in mind is extremely useful. Now coming to timing of surgery, there are only 5 indications where we need to, in brachial plexus. Acute open injury, always immediate exploration, or if it's not bleeding actively, in the first available OT list. Closed upper plexus, less than 3 months. Global palsy, 6 to 8 months. Mixed injuries, if recovery is not according to order, then within 3 to 6 months. Parsonage Turner, very rare indication, up to 6 months. So an example of each, a stab injury, level of injury is a 5-6 root, both have been divided, and that is a result of primary repair at 18 months follow-up. A late presentation, 5-month post-injury, the recovery is not according to order. As you see here, there is no elbow flexion, no wrist extension, only the median, the ulnar nerve is there, and there is no thumb flexion. So if you see the clavicle malunion is there is rupture of the anterior and posterior division. So we can put long nerve grafts, and long nerve grafts do work in brachial plexus. So this is as such not very long. You can even extend it right up to the infraclavicular region. So we have grafted the anterior division to the musculocutaneous and median, posterior division to the radial and axillary. And that is the result after the nerve grafting. Yeah, so this was a slide. Indications of surgery. So acute injury, always explore immediately. Closed within 3 months. Global palsy, 6 to 8 months. In mixed injury, if recovery is not in order, then also again 3 to 6 months, and Parsonage Turner before 6 months. So in stab injury of neck, this is an acute stab injury. So there is a C5, C6 complete division, and that's a result at 18 months follow-up. In late presentation, this is a patient who has presented to us 5 months post-injury. Only shoulder abduction and part of finger flexion is present, mainly the ulnar component. So that's the intraoperative finding. We can put long nerve grafts. We have put for the musculocutaneous and median from the anterior division, the radial and axillary from the posterior division. And that's a result at 18 months follow-up. Now coming to neurolysis, it does work in brachial plexus. It's a controversial topic, but we always find when we explore, as seen in this patient who had no recovery of shoulder and elbow at 5 months, after exploration, intraoperative stimulation with the nerve stimulator, we use this kind of intraoperative stimulator. What happens is it basically increases the metabolism, blood flow, membrane permeability of the nerve. And extensive articles are there, mainly from the John Hopkins group by Professor Thomas Brushardt, who have really documented that brief electrical stimulation does promote increase in motor regeneration, axonal regeneration. And this is the same patient after the exploration and neurolysis and intraoperative stimulation having a good outcome. Here another example, associated vascular injury. Everything is stuck at the level of the vessel injury. We release it, ligate the thrombosed axillary vein, and that is the result at the end of 18 months. And another girl with an infraclavicular injury, patchy recovery. The musculocutaneous nerve was avulsed, so we did a nerve grafting. Median nerve and the radial nerve was only neuralized and stimulated intraoperatively. And that is the result, no need for any further tendon graft or secondary procedures. Now coming to nerve transfers, which is the most exciting part of brachial plexus injury. So you need to clinically examine well, as I said in the first few slides. So in this patient, if you see there is good elbow flexion, there is external rotation, and there is abduction up to nearly 90 degrees. So it's an isolated deltoid palsy. So what we need to do, or all we need to do, is a radial nerve, that's a triceps branch to the axillary nerve. And I'll come to in detail the various permutation and combination of this. So this is the nerve transfer we did, and that is at 1 year follow-up. So nerve transfers have revolutionized brachial plexus reconstruction. But then if it is a complete C5, so you need to reconstruct the suprascapular nerve also. So that is how we reconstruct the suprascapular nerve. So the incision we put is just a skin crease incision. It's very cosmetic and you can access the entire plexus. A small trick in identifying the suprascapular nerve, it just follows the omohyoid. So once you detach the omohyoid and retract it, the suprascapular nerve just follows it and you can comfortably do it from the front. There are many approaches or in papers suggesting of posterior approach. We have done quite a few, but then we always are able to find the suprascapular nerve from the front comfortably and do the cooptation. So the spinal accessory does not reach directly to the suprascapular. Many times you need to tunnel it under the fat pad because this fat pad occupies a lot of space. So you tunnel it and bring it underneath and directly co-opt to the suprascapular nerve. Now coming to the Somsack transfer. Originally, Somsack described use of the long head of triceps branch of the radial nerve to the anterior division of the axillary nerve. The reason he did that, because the anterior division of the axillary nerve predominantly supplies nearly the half, the anterior, middle, and even some parts of the posterior half of the deltoid. If you take away the posterior division, which goes to teres minor and the cutaneous branch, and also posterior division of deltoid, then you are basically reducing his concept at that time was that you are avoiding an adductor or an external rotator, which can also cause some amount of decrease in the abduction. Whereas now, and even after Susan McKinnon, innervating the entire axillary with a bigger branch, which is a medial branch, is also becoming very popular. And this is something which we do more often nowadays. So this is the use of the entire median head of the triceps. And you can, if you dissect the axillary nerve, take away all the extra fat and fascicles, you can actually get a good cooptation and get the entire axillary nerve into the triceps branch. We have been doing anterior approach from the beginning, even after Somsack transfer, because we were influenced by Professor Bertili's work. And we were also very familiar with the axillary anatomy because we were doing a lot of obstetric work where we release the teres major and the lat dorsi and do tendon transfers. And this is a beautiful picture by Professor Clifton. If you see the axillary nerve in the quadrangular space, this is from the front. That's a teres major actually. And there is anterior division, posterior division, and branch to the teres minor. And this is a teres major muscle. And if you trace the triceps branch, even the long head, as it goes distally, you can get few branches. So this is actually just done today afternoon. So if you just go into the quadrangular space, pull the teres major little away, and you can easily hook the axillary nerve. So that's the axillary nerve. And if you see the small dent in between, so the anterior and posterior division can also be quite easily and comfortably made out. And you divide it as high as possible so that you can get a good length for cooptation. So this is how it looks, axillary, the entire axillary nerve, the branch, the teres, that's a teres major, and that's a long head of triceps branch. Now we have taken only the anterior division and done the cooptation. When we do it in the axilla, we always use tissue glue for this after the co-opt suturing. Now coming to C5 and C6, we also need elbow flexion, and the classical article by Oberlin, which has been a landmark contribution in the brachial plexus reconstruction. But when it comes to doing a single versus double nerve transfer, our original paper which we did was doing a spinal accessory to suprascapular and Oberlin transfer, that is ulnar to biceps, and we published our initial work in this paper. We used to get good results, but most of our cases were predominantly pure 5 and 6. So if there is C7 involvement and there is weakness of the ulnar nerve, then you can have problems. So Susan McKinnon and Oberlin at the same time around 2006 came up with a dual nerve transfer. And this is what many centers do nowadays. But there is a little difference in the way many people do. So the way we identify the fascicle is to take the fascicle, we identify by stimulating the fascicle, and I will show the picture where exactly we take it predominantly. And you take a fascicle. When Oberlin first described, he said to take 10% of the ulnar nerve. So we can even now, subsequently, many of his articles and with personal communication and his presentations, we can take a bigger chunk of ulnar nerve. So if you want to take a bigger fascicle, it is better to take from the ulnar nerve. So this is the classical dual nerve transfer, ulnar to biceps, median to brachialis. Many times what happens is the biceps branch is short in length, so you cannot, the ulnar nerve gets a little lifted up. So to avoid this, what people did, or what many surgeons propagated, was taking the median to the biceps and ulnar to brachialis. But again, this is not done frequently. Susan McKinnon again speculated that motor re-education, because median nerve also gives rise to the pronator branch. So it is a pronator basically. And when you convert a pronator branch from the median nerve into the biceps, it can confuse the patient because biceps is a supinator. So she again said that this should not be done unless we find that there is intraoperatively median is more stronger. So this is again a beautiful picture by Professor Clifton. This is the region where we take. So it's a cut section at the mid-arm. So if you see the median nerve in the mid-arm, predominantly on the towards the biceps is the sensory component coming from the lateral cord, and predominantly in the medial side and the posterior side is the motor component. The real posterior, or at the 6 o'clock position, is the anterior interosseous nerve. So this is something you should avoid. And in the ulnar nerve, it's basically mixed. So if you take a big chunk of ulnar nerve, it will have a motor nerve definitely. So that is why ulnar nerve was originally propagated by Oberla. And this is a patient, and this is a multiple nerve transfer. This is a quadruple nerve transfer, triceps branch to axillary, and the Oberlin transfer, and the spinal accessory to suprascapular. And that's the kind of result we can get. So very consistent results can be achieved by doing this multiple nerve transfer. Are you able to see clearly now?
Yeah.
Yeah. So coming to tissue glue, more and more we are using tissue glue in nerve transfers. And the reason is that one is it keeps it secure. And the other advantage, especially when you do in children, it keeps it secure. Their even movement does not disturb it. And if small bleeding or hematoma is also avoided because the glue sort of practically seals it. In case you have a hematoma sometimes, very rarely, then it does not disturb the nerve coaptation site. Now, can you take the ulnar nerve fascicle in a weak hand? And this is a very controversial topic. So now Oberlin also agrees that you can take it in patients who have got a weak grip. Initial paper was less than 10 kg of grip, you should not take the ulnar nerve fascicle. But then this is a patient who had 4 kilogram preoperative grip, and that's the result you can get. So we studied a group of patients between 2013 and 17, and they were predominantly in the C5, C6, C7 group with a pre-operative weak grip. You support the grip and check the grip strength. All had grip strength less than 10 kilograms. And the outcome was, with minimum follow-up of 14 months, their post-operative grip improved to 10 kilograms. And more than grade 3 and more was 18%, that is 81% out of the 22 patients. So these 22 patients, 18 patients, if we are not done because they had pre-operative weak grip, they would not have benefited with the nerve transfer. Do we need to neurotize the triceps? Very rarely, because most often the triceps will recover over a period of time. But in special instances, as in this patient, he had a very high level amputation in the lower extremity also. So triceps is extremely useful for lifting off, and in case of wheelchair, and if you want to use a walker. So in such cases, triceps is very useful. For the wrist, we have done wrist fusion. Now, as we move to the wrist, can we re-innervate ECRB with the median nerve? And this is again what is now we call as a distal nerve transfer. And this is the sort of hottest topic in brachial plexus reconstruction. Many times with sort of tenodesis effect, they will bring it to neutral. But if you just load them with some weight, as seen in the lower picture, the wrist goes into flexion. So pronator quadratus branch to the ECRB transfer is the transfer which is now very in vogue, and we have also started doing it in cases where there is weak wrist. It's a very good transfer to do because the pronator quadratus branch is very long, and once you turn it around, you can comfortably reach the ECRB branch. So this is the same patient. The post-operative result, if you see here, pre-operatively, if you just loads the wrist, it goes in flexion. Post-operatively, is able to bring up to neutral, and this improves over a period of time. So they are able to really grasp onto objects with good grip and grip strength. Now, if you have a failure of nerve transfer, what are the options? So these are the available options. Triceps to biceps, as was also seen in case of the patient which Dr. Sabapathy presented, is a very good transfer. You can take the entire triceps, or you can take part of the tricep, that is a long head of triceps. For shoulder failure of spinal accessory to suprascapular, we do trapezius transfer. For augmentation of existing elbow flexion, which is weak, we do a Steinler's flexoplasty, which is again a very useful surgery. Before doing Steinler's, it is important to keep in mind that the wrist extension should be good. And that is a really strong elbow flexion the patient has got after Steinler's flexoplasty. And of course, FFMT, when other options are not available, when the hand is good, we can do FFMT also for elbow flexion. Now coming to global palsy, only in children we have done opposite C7. And this has been a bias in our unit, but we find the reason why we did or we did not do so many opposite C7s were we were not very happy with the hand function in these patients. So we were doing classical cross C7, the entire C7 we were taking and putting it to the medial and the posterior cord. And that's the kind of recovery you can get. Still, the musculocutaneous is sometimes not very strong. You see here, if he is powering the finger flexors using the opposite hand grip. So we did a FFMT for the elbow flexion, and we can restore good elbow flexion. Now he has got good shoulder, elbow, and hand function. In adults, what do our patients want? So they all get injury from a bike, but then they all need to go back into the bike because that's what their job entails. So getting onto the bike is one of the things with the patient is really desperate following a brachial plexus accident injury. And other things, what they want is they want to be independent. They need to eat. Of course, they use the other hand. They should not have a paralyzed appearance, and they should be free from pain. So these are the things a global palsy patient wants. They don't so much desire a shoulder abduction or lifting the shoulder. So our philosophy has been, we do what works, and each surgery which we do should give an optimal result before we move on to the next. And we are able to do from nerve transfers to functioning muscle transfers and arthrodesis in our unit. So this is our protocol when we see them early. First stage, spinal accessory to musculocutaneous. Second stage, wrist fusion with CMC fusion at the same time and trapezius transfer. And following the third stage for finger. So spinal accessory to musculocutaneous with 15 to 20 centimeters of nerve graft. And we have found it gives grade 3 or more in more than 80% cases. If the trapezius is weak, we use intercostal to musculocutaneous. Once the elbow is stabilized, once the shoulder and the wrist is stabilized, we go for the hand. Can we use trapezius after the spinal accessory has been used up? The answer is yes, and we have had good outcomes because we take the spinal accessory low down after sparing the branches to the trapezius. So this is what we get. But when we see them late, we do functioning muscle transfers. And in 112 cases, of which we have studied close to 60, we found that more than 82% have got M3 plus power. Now we always have selected gracilis. We have not done any other muscle. And the thing to remember with gracilis, though it's a strap muscle, and unlike the pinnate muscle, there is a difference in the cross section. And the pinnate muscle also has got what is called anatomical cross section area and a physiological cross section area. So basically a pinnate muscle is very good for resistance and increasing heavy weight, whereas a strap muscle is good for less weight but very good movement. So what we need in a brachial plexus in a global palsy is not to lift heavy weight, but to get good range of movement and ability to place the hand in space. So the vessels we use, thoracoacromial when we take the spinal accessory, the long thoracodorsal when we take the intercostals. So corresponding to the nerve where we use, this is a donor vessels of choice. In global palsy, when we see them late and spinal accessory is not there, we do a intercostal nerve transfers, intercostal as our donor for the FFMT. As soon as the elbow flexion starts working, we do a wrist fusion, and they dramatically improve even after the simple wrist fusion, even without any hand function. When there is subclavian artery injury, we look for the collaterals. So we do an angio. The collaterals basically develop between the thyrocervical trunk and the circumflex scapular vessels of the axillary artery. So this is a patient who had a complete block at this level, and that's a collateral coming, on which we did a FFMT for elbow flexion. Now finally coming to the finger flexion, what do we do? So we have only 4 options available. we started using these magnetic gloves, which was basically used. The patient has got good elbow and wrist, but there is no hand flexion in the hand. So he wears his gloves, and we give them these contraptions for different purposes. So here is an example: good elbow flexion, trapezius and the wrist fusion has been done. So this is how he rides a two-wheeler. He uses the specialized wrap which has been made for the handle of this two-wheeler, and then he goes on to his work. Of course, he needs a specialized license for this. So all the 4 steps, once we have done spinal accessory to musculocutaneous, trapezius transfer and wrist fusion, we go for the FFMT. So people who want finger flexion, unlike the previous patient, they need to have a FFMT done for finger flexion. So that is the level of range of movement they can get following finger flexion. So there's a strong wrist is stabilized, elbow is strong, shoulder is moved by the trapezius transfer, and finger they get a hook grip. Now coming to, if we don't have an option of finger flexion, that's an FFMT, we use the biceps to FDP, and this is our more popular choice of reconstruction now. We extend the biceps tendon with fasciolata graft and fix it to the FDP tendons. So they get good finger flexion, but for extension of the finger, we again give them this extension glove, which keeps the finger in extension. And that is the same patient we saw before. So he has undergone a FFMT for elbow flexion. In these patients, we extend the FFMT with the fasciolata graft, but we do not detach the entire biceps tendon. So that is what makes him flex his finger. We are able to do remote monitoring of our patients by now WhatsApp and internet. And we also give this guide where to mark the points for stimulation. Now coming to distal nerve transfers, or very distal nerve transfers. So when we have a high ulnar nerve injury, we do an anterior intraosseous, that is the pronator quadrator branch to the ulnar nerve. But then this has not been as successful as the initial papers have said. And even a recent article from Jamie Bertilli says that no patient had a claw correction, and patient still had an extension lag, and no deficit in pronation strength was noted. And he analyzed and said, their team said that the low donor to target ratio and the proportion of fast fascicles are one which is responsible for loss of intrinsics. So sensory, we use ulnar to the sensory branch of the thumb, the median nerve. Now in severe pain, when you have severe pain, we can do a radial nerve to median nerve transfer. It is especially very useful in children who are chewing their fingers. You can do a distal nerve transfer. So what we have done, we select the at the 7 centimeters from the wrist joint, the radial nerve is end to side co-opted to the median nerve, and this really reduces the pain. So in distal nerve, our experience says that median to ECRB is effective. Sensory is very effective for both median and ulnar nerve. For pain, radial nerve to the median nerve is very effective. Finally, we talked about a lot of psychology. Brachial plexus not only is a physical impairment, it is also a mental impairment. If you really analyze paraplegics who are more devastated, or the injury is more devastating, brachial plexus patients are more depressed as compared to paraplegic. And the reason why they have analyzed is that the spinal cord injury patients have got a lot of support group, and they are sort of accustomed and used to their condition as compared to a brachial plexus injury. So we analyzed a series of 50 cases. If you see here, this patient has got very poor, moderate recovery, but absolutely no depression. Poor recovery, but mild depression. A very good recovery, but then severe depression. So when you analyze, we use this Beck's depression score, which has been used for spinal cord injury also, and show SF12. We found younger age group, average or a graduate, not very highly educated, middle income, extreme pain, and the dominant hand. These were the main causes of poor outcomes as well as depression in patients. So if you have these 5 things preoperatively assessed, and you do a preoperative depression scale in these patients or in all your patients, you will realize, or you can sort of find out who will do well after surgery. So it is what the patient does with what we have given them. So this is a patient we have seen a couple of times, and he is very happy now to promote brachial plexus reconstruction, and he has also referred many patients to us, and this is him at the time of his marriage. So I bring you greetings, and I welcome any trainee who is interested to visit us. This is our Ganga Hospital Brachial Plexus team. And I thank all the teachers who have guided me through this journey. They have been the sort of guiding light for us. And this is a typical clinic where we have close to 10 patients who have been reconstructed at any given time. Thank you very much. And sorry for the glitch which we had. Thank you.
Thank you so much, Harry. What a wonderful talk to listen to. So great to learn such a condensed volume of experience pulled together in such a nicely structured way. It was really, really enjoyable. Another fabulous talk. It's been a really, really great session. We have a couple of questions. So I think we're going to promote people to ask questions live. So the first is, I think Luke Gagan has a question for Dr. Sabapathy, I believe.
Hi, Dr. Sabapathy. Thank you very much for your talk. It's great to see you again.
Thank you.
Just a quick question, but probably quite a broad question. What single piece of advice would you give to yourself at the start of your career, looking back now?
Oh, that's a good question. Then probably you would, if you had worked with some people who have been driven, no? And you also just have to see that you need to achieve it, that's it. And they give you a feeling that you can do it, no? That's the question of you can do it. You must have an idea. And everybody who starts having a career, they need to put their pen to paper. No? They always tell them, young people, you just take a pen and paper and just start to answer a question. No? What would you like to be when you're 45? Okay. And just, you don't have to show it to anybody, I tell them. You just write whatever you like and then work backwards. Then you'll find now you can achieve anything you want. That's really the thing I will say.
Thank you very much.
Thank you very much for the pearls of wisdom, many of which I wrote down so many pearls of wisdom from my time there. There's a question in the Q&A, I think of Dr. Harry. How long do you wait after a nerve graft from SAN to MCN for recovery? It's from Ramani Venkat. So.
Yeah, so basically we need to wait at least 9 months. So the recovery starts grade 3, takes around 9 months to 1 year. So we do the next procedure around 1 year. So we tell the patient it's a 3-stage procedure. First we do the nerve transfer. At 1 year we do the trapezius transfer and the wrist fusion. And 3 to 6 months later we can do the reconstruction for the finger flexion. So roughly 1 year.
Thank you very much. I'd like to thank both of our very esteemed invited speakers from the session. Always a pleasure to listen to their thoughts, their experience pulled together in such a beautifully structured way for us to benefit from. So thank you very much. Really enjoyable.
Thank you. Thank you very much. Thank you.
The final session is the best paper competition, and we will chair this with Dr. Sabapathy. This year we have some wonderful submissions, 27 from around the world. We'd like to give special thanks to Matt Gardner, Surgical Specialty Lead for Hand and Plastic Surgery at the Royal College, for shortlisting with us. We have 6 finalists. Each of them will have 8 minutes to convince the judges that they are worthy of a Stoke Mandeville Ganga prize. After each presentation, there will be 1 question from each judge, and then the judges will convene and the winners will be announced. Thank you, Ganga, for sponsoring the prizes. And we would like to invite Dr. Sabapathy to say a few words.
So thanks so much. They always say, no, you reserve the best for the last. So we started off with very inspiring talks, and then we saw those things in action. And now we'll see the potential people who are going to give such lectures in the future. So thanks so much, Rebecca and James, for doing this, because I consider every prize is a big prize. So I'm very thrilled to listen to the presentations.
So thank you very much, Dr. Sabapathy. So this is a really exciting time for plastic surgery, for research and innovation, combining academia with clinical work. So our judges are great examples of how to do this really well. So they are Fadi Issa, Associate Professor at the University of Oxford and consultant colleague here at Stoke Mandeville. Then we have Jason Wong, who is a professor at the University of Manchester. Hi, Jason. And also Professor Paul Verker, professor at the University of Groningen in the Netherlands. So thank you all very much for your time and expertise.
So the first presenter is Luke Gagan. He's a plastic surgery trainee at the John Radcliffe Hospital.
Okay, so welcome to my virtual presentation. My name is Luke Gagan. I'm currently a core trainee based at Oxford, and I'll be sharing the results of our study entitled Predicting Improvement in Hand Function and Symptoms Following Carpal Tunnel Decompression Using Machine Learning Algorithms. I have no conflicts of interest to declare. In the UK, 1 in 1,000 people will undergo carpal tunnel decompression at a cost of around £50 million per year. It's generally considered to be a safe and effective treatment, although 25% of patients do not experience a meaningful improvement in symptoms and 8% deteriorate following surgery. Carpal tunnel decompression has been identified as a procedure of limited clinical value by NHS England. Treatment is only recommended for patients with objective evidence of neuropathy, severe symptoms, or mild moderate symptoms following a trial of non-operative management. This recommendation was controversial and based on limited evidence. If we can identify who will benefit following carpal tunnel decompression, we could optimize outcomes at the patient level and reduce unnecessary cost and complication at the population level. Now, the first step in identifying who will benefit is defining improvement following intervention. This is conventionally done using patient-reported outcome measures, such as the Quick Dash, which we can see here. This is an 11-item PROM that looks at various aspects of hand health, including function, social aspects, and symptoms such as pain and tingling. And previous attempts to predict patient-reported outcomes after carpal tunnel decompression have failed to capture these different aspects of hand health by only considering the composite PROM scores. Put contextually, improvements in numbness following decompression may be offset by difficulties performing recreational activities due to the presence of a painful scar. Thus, using traditional PROM scoring, clinically relevant changes in hand health may not be captured. This project had 3 aims. The first was to refine existing conventional outcome measures to identify functional and symptomatic improvement through modern psychometrics. The second was to develop and validate machine learning algorithms that can predict functional and/or symptomatic improvement. And the third was to understand how these algorithms make predictions and build decision trees that can be immediately implemented into clinical practice. We use factor analysis to demonstrate that the Quick Dash has a 2-factor solution. This means that items 1 to 6 measure the same underlying construct, which we have called hand function, whereas items 9 to 11 measure a distinct underlying construct, which we've labeled symptoms. Patients were said to have improved following intervention in terms of function or symptoms if their Quick Dash subscores were greater than the MIC, or the minimally important change score. We define this MIC as half a standard deviation of their baseline scores. We developed algorithms using a regional database of 1,889 patients who underwent carpal tunnel decompression at a single institution. Our dataset contains 61 predictors, including demographic factors, comorbidities, Quick Dash item response scores, and EQ5D5L scores. All patients underwent carpal tunnel decompression through an open approach. Surgery was performed in all patients with neurophysiological evidence of carpal tunnel syndrome, or those with clinical features that did not improve following non-operative management. Quick Dash data were randomly split into training and test sets. We used bootstrap resampling to minimize the risk of overfitting, and each model was iteratively adjusted through hyperparameter tuning. The model iteration with the highest mean accuracy was then selected and applied to the test dataset for final evaluation. We did this 5 times for 5 distinct models of increasing complexity. This included logistic regression with elastic net regularization, or EN, a K-nearest neighbors model, or KNN, a support vector machine, or SVM, an artificial neural network, or ANN, and an extreme gradient boosted random forest, or XGB. Models were compared by classification accuracy. We then developed simple heuristic decision trees that could predict whether patients would improve in terms of symptoms or functions without the need for sophisticated algorithms. We performed this analysis using chi-squared automatic interaction detection, and this enabled us to predict whether patients would improve based on their responses to just 2 preoperative questions. Data were available from 1,889 patients. Now, using traditional composite scoring, 63% of participants improved following intervention, i.e. their total composite score was greater than the MIC. However, when we accounted for the two-factor structure of the quick dash, 49% of patients experienced improvement in function and 76% of patients experienced improvements in symptoms. This tells us that conventional scoring of all quick dash items on an ordinal scale may mean that clinically relevant changes in upper extremity health are not detected. These tables demonstrate the classification accuracy of each trained model for predicting both functional or symptomatic improvement. The best performing model was an extreme gradient boosted random forest, which was able to predict meaningful function improvement with an accuracy of 0.72 and meaningful symptomatic improvement with an accuracy of 0.77. Now, in order for these findings to have any clinical impact, our algorithm and all predictive variables must be available to clinicians. Now, this isn't pragmatic and it's certainly not feasible. So to improve the applicability of our findings, we devised heuristic decision trees for functional and symptomatic improvement. These can predict whether a patient will make a meaningful improvement based upon responses to just 2 preoperative questions. Here we can see that 93% of respondents who had pain that was caused severe difficulty when sleeping, but were otherwise in quite good health, had a 93% symptomatic improvement. Such decision trees can easily be implemented into clinical practice to guide decision-making. This is a large body of work that has 4 main implications. Firstly, we've demonstrated that the interpretability of the quick dash is improved by separating both functional and symptom subscales. Conventional composite scoring may mean that clinically relevant changes in upper extremity health are not detected. Secondly, we've developed algorithms that can predict clinically meaningful improvement in either hand function or symptoms following carpal tunnel decompression, based upon 61 predictors. Thirdly, we have developed heuristic decision support tools that can be readily implemented into clinical practice to identify patients who are likely or unlikely to benefit from carpal tunnel decompression using only 2 preoperative questions. And finally, combining contemporary psychometrics and machine learning in clinical decision support tools can support patient-centered and value-based healthcare through a data-driven approach. Our algorithms can be used for expectation management and to rationalize both treatment risks and costs associated with carpal tunnel decompression. Thank you very much.
Great, thank you so much, Luke. That was a great talk, kept to time. I'd like to say I understood a lot of it, but I think you probably lost some people in the all the algorithms and the data decision trees. But it is incredibly impressive. I have a question really about that, which is to do with your sample size. When you're doing something so complex and putting patients down different decision trees, and you have 1,900 patients or so, how confident are you that the data that you're generating and the models that you're generating are actually accurate and usable? And how do you actually know how many patients to start off with when developing these techniques?
It's a very good question, Fadi. And just to sort of pick it apart, I think what you're asking is, are our results generalizable to a wider population, and have we got a big enough sample in order to confidently say that? And I think in answer to your question, it's difficult to say what the optimal sample size should be, as what we're doing is looking for relationships between predictor variables and outcomes. What we've done here is we've used a prospectively kept regional database that has, more than 2,000 data points for, if we consider each patient as an individual data point and all of their associated metrics. Now, like you said, when we go down these decision trees, they get smaller and smaller in terms of the number of patients at each node, but there isn't a consensus in terms of what the optimal number of patients per node is. All we can say is that the results that we have generated are obviously generalizable to the cohort that we've got them from, but future work will determine whether or not these are generalizable to a wider population and cohort of individuals.
So Luke, what would your next step be in validating what you've created?
So in answer to your question, there are sort of 2 lines of work that stem from this. The first is to externally validate all of the algorithms that we've developed in a completely new set of data that our algorithms haven't seen. What we've done so far is we've done bootstrap resampling, which basically means we slice the data up in lots of different ways to make sure that our data isn't overfit essentially to the data that we have. What we would like to do is externally validate that on a set of data that our algorithms have not yet seen. That will give us a better reading in terms of the accuracy. What we then like to do is, from a heuristic decision support tool perspective, is to implement these in clinical practice to see whether or not patients do improve following intervention, just using a generic or global rating of change to basically say, yes, I improved following my intervention, and looking at the decision support tool, it said that I would.
Thank you. I'll pass on to Paul and Jason if they have any questions.
Thank you, Ferdy. Thank you, Luke. When I hear a talk like yours, I think it's about time for me to retire, because it's becoming really, really difficult for me to follow all this. I used to work in a unit where we used to operate about 750 carpal tunnels a year. And for me, the most deciding factor to operate was when somebody told me, well, I wake up during the night and I flick my hand and then the symptoms go away. And is that what your complex analysis is actually showing, that is right?
In a way, yes. If we look at the final decision support tool that we put up there, what that's shown is if you have severe pain when you're sleeping, but you're in otherwise good health, i.e. you don't have any other reason to have pain in your hand, then it's likely that you will improve from a symptomatic perspective. But what we've done is we've essentially used a data-driven approach to sort of affirm that.
I know. I'm not trying to. I'm just trying to get it back into the clinic. And I think it's impressive how you've analyzed all that and how you've really brought it back to something that is still understandable for a clinician. So thank you very much.
Thank you.
Thank you, Luke. That was a very interesting talk. I wanted to ask you two small questions, actually. One is about how does mental state of the patient play into all this, and how big a confounder do you think that's going to be when it comes to these algorithms?
It is a very interesting question. I think, sorry, just to sort of immediately answer it, my sort of gut response is that it's a problem that plagues sort of outcome assessment and psychometrics. In terms of how we sort of accounted for that in this line of work, all PROMs were sort of administered on the morning of surgery. So we had sort of a single time point at which all of these assessments had sort of taken place, and then post-operatively they were measured at 3, 6, 12 and 24 months post-operatively. So there is sort of an element of sort of single time point bias. And also when you say mental state, it's a very interesting point, because people's sort of outlook on things has a huge bearing in terms of their sort of patient reported measures of well-being. So I think it's more of a global problem with psychometrics that is difficult to account or control for.
Great. And the second question was, so you gave this lovely table at the end where you show 95% if they're shaking their hands at night and don't have any other comorbidities. Can you, from your data as it is just now, can you predict who to operate on, who to inject, and who to leave alone?
So the results of our study tell us who will benefit from both a symptoms perspective and a function perspective only following an open carpal tunnel decompression. There's no reason that these data can't be applied to other cohorts of patients that have received other interventions. It's the same framework that we would use, just a different set of data in order to do so.
Great, thank you very much.
Thank you.
Okay, next up, Lisa Hugendam, who is from Erasmus MC in Rotterdam.
Thank you for the opportunity to present our results here. And today I would like to tell you about our recent study on a machine learning model to predict improvement in pain after treatment for hand and wrist disorders, and also tell you something about the clinical implementation of this. So as you know, for patients with hand or wrist disorders, there are usually multiple treatment options available, such as splinting, injections, or surgery. And it can be very difficult for a patient to decide what the best treatment option is. And generally, clinicians inform their patients based on the outcomes of previously treated patients. But it would be better to have prediction based on the individual characteristics of the patient. And for this, prediction models can be a very useful tool. Now, generally, we see that prediction models are made for individual diagnosis. And this is something that we've also done within our own research group. But we were wondering, but this approach is not very time-consuming, and it is often underpowered for more rare conditions. That is also very impractical in terms of clinical application to maintain all these separate prediction models. So we were wondering whether it is possible to create a single prediction model to predict the probability of a clinically relevant improvement in pain after treatment for hand and wrist disorders, and also for how many diagnosis treatment combinations the model performance would be good enough. So for this, we used data from the hand wrist study group cohort, which is a collaboration with expert clinics in the Netherlands, who have 25 locations for hand and wrist care. And all our patients are invited to complete patient-reported outcome measures. And for this specific study, we had almost 25,000 patients with complete data for the study. So we defined improvement in pain as reaching the minimal clinically important difference, which we defined as a 2-point improvement on a 0 to 10 scale. And we compared 3 algorithms. So the simple logistic regression, and also 2 decision tree-based algorithms. For model performance, we looked at 2 measures. We looked at the area under the curve as measured for discrimination, and we looked at calibration, which is a measure for the reliability of the predicted probability. So basically, if we have 10 patients who all have a predicted probability of improvement of 70%, do we also observe that 7 out of those 10 patients will improve? We thought that clinical application would be very important, so we used only variables that were available before the first consultation with the hand surgeon. And in our case, this included patient characteristics, pre-treatment pain scores, and also the diagnosis and the treatment. For clinical application, we evaluated model performance overall and also per diagnosis treatment combination. To be good enough, in our opinion, we said that our model should have an area under the curve of at least 0.75 and good calibration. So here you see the approach that we took for this study. So we split our data into training data, validation data, and test data. And on the training data, we created our models. And then on the validation data set, we tested those 3 models and selected the best performing model, which was then tested on a separate test data set where we evaluated model performance overall and also per diagnosis treatment combination. And that was, we used that to determine whether the model would be good enough for clinical application. So here you see the results overall. So the area under the curve was quite high, 0.87. And on the right-hand side, you see a calibration curve, which shows the calibration of our model. And what is important is that the gray area nicely falls around the red line. So in this case, we had good calibration. When assessing the model performance based on for the specific diagnosis treatment combinations, we found that for 26 out of the 37 diagnosis treatment combinations, model performance was sufficient. And here you see an overview of the diagnosis treatment combinations that we included, and all those in green were sufficient for clinical application. I've already mentioned a few times that we think clinical application is very important. So we created a dashboard for our clinicians to use. And unfortunately, it's in Dutch, but I'll talk you through it. On the left-hand side, you see the patient characteristics. So this is information that we receive from the first questionnaire that patients complete prior to the first consultation. So this information is available to the clinicians. And above, the clinician chooses a diagnosis and a treatment during his consultation. Using that, we can obtain the probability of improvement, which is shown as a percentage and also shown visually, so that it can be explained to the patient. So concluding, using just a single machine learning model, we can accurately predict improvement in pain for 26 hands and wrist diagnosis treatment combinations. Our model requires patient characteristics, the pre-treatment pain score, and also diagnosis and treatment as input. And we have made this available for clinicians for real-time use during their daily practice. In the future, we would like to evaluate the added value of our model and also evaluate how this is experienced by patients, clinicians, and whether this has any impact on patient-reported outcome measures. Thank you for your attention. Do you have any questions?
Thank you so much, Lisa. That was another great talk that is, showing us how these techniques are likely to start to enter clinical practice. Very impressive. I found it surprising that you could even combine all these different hand and wrist conditions into one algorithm, because we often think of them as separate entities. They're complex pathologies and they have different pathophysiology behind them. If you can apply it to all these hand and wrist disorders, could you apply a similar algorithm to essentially all musculoskeletal disorders, do you think?
Thank you for that interesting question. What we've seen so far in our own research group is that even though all the diagnosis and treatment combinations are really, well, specific entities, as you mentioned, we do see quite a comparable pattern in when we evaluate the outcome. So we see that most patients improve. Patients with more severe symptoms improve more than patients with less severe symptoms, obviously. And because we noticed the same patterns each time, we thought like we should at least try one to see whether it is possible to predict this. I think it's very interesting to apply this also on an even broader scale. What was a challenge for us was that it was impossible to use the specific diagnosis treatment combination as input for our model. So we decided to use whether it was a surgical or non-surgical treatment, and also the measurement track that the diagnosis treatment combination would be part of. So those were the input variables for our model, but we evaluated performance really per diagnosis treatment combination. So I think it would be.
Yeah, that makes sense. Thanks, Lisa.
Thank you, Lisa. Very interesting work. I'm intrigued by those 11 of 37 diagnosis treatment combinations that did not reflect what you really wanted to see. Can you allude a little bit to those?
Yes, I think that was also something that we're very interested in. Like, why does it work? Why doesn't it work? And one of the things that I notice is that specifically for wrist disorders, it is very difficult because, like I just mentioned, we did not include the specific diagnosis treatment combination, but we included the measurement track. So, for example, within our wrist track, we see a lot of variation in the types of diagnosis treatments that are in that track. So we have wrist arthroscopy, we have the Kervans tenosynovitis, and these are, I think there's a larger range of disorders in that specific measurement track than we see in some other measurement tracks. I think that is part of the reason why it is very difficult for those conditions to make a good prediction model based on this approach.
Yeah, thank you. I'd like to discuss the trigger finger release, but unfortunately we have to move on. And I'd like to give Jason the chance to.
Thanks very much, Lisa. Very interesting data. I wanted to ask you, can this type of modelling be used to predict what operations or what types of patients would develop CRPS?
That's a very good question, and I think it would be amazing if we would be able to do that. So one of the issues within our specific data set is that we don't record complications in such a way that we can use it easily as researchers. But I think that the overall idea, so if you would have the data available, I think this approach will work, especially because CRPS, of course, doesn't happen that often. So you can use all the numbers to make a good prediction model for that.
Thank you, Lisa. Next up, Alice Lee. She's a trainee in Stoke Mandeville.
So thank you once again to the organising committee for inviting me to speak about my project. So I'll be presenting COPET, which stands for Chronic Pain After Extremity Trauma. And this was a multi-centre observational pilot study. As Rebecca has mentioned, I'm currently a plastic surgery CT1 trainee in the Thames Valley Deanery. And I'd like to say a special thank you to Dr. Wickham and Mr. Hetiaraki for co-supervising this project and for helping me to prepare the slides. So pain after traumatic injuries is a significant issue for patients. And there are series in the literature which show that moderate to severe pain can affect patients up to 7 years post-injury. Tibial diaphysis fractures are the commonest long bone injury, and that was the model that we used for our study. And the reason that we really focused on pain is that most studies to date in the area of lower limb trauma have focused more on surgical techniques or functional outcomes as opposed to pain, which we know is a significant priority for our patients. So in terms of our aims for the study, we wanted to describe the acute and chronic pain characteristics after tibial injury, of which there is quite limited data in the literature, to identify if early nerve dysfunction was present, and indeed if that nerve injury led to chronic pain, and particularly neuropathic pain. And as a more general aim, to see whether this study design would be feasible for a further interventional study. So in terms of our methods, this was a multi-centre cohort study across 5 major trauma centres in London, and we did 12 months each of recruitment and patient follow-up. So in terms of our inclusion criteria, we included patients aged 16 years or above with adequate understanding of English in order to perform our outcome assessments and measurements. They had an isolated fracture of the tibial diaphysis, and they had to be recruited within 48 hours of arrival in hospital so that we could capture the acute nociceptive pain element. So here you can see a table of our assessments throughout the study up until 12 months. So we did a baseline assessment of the injury, of the patient's medical history and their examination. And then we looked at sort of 3 main groups in terms of our outcome measurement. So firstly, pain. We used a visual numerical rating scale from 0 to 10, as well as the analgesic consumption and side effects and the brief pain inventory short form. We also looked to see if there was any evidence of nerve dysfunction. So the main test we used for that was a Weinstein monofilament sensory testing. And we also looked specifically at a measure of neuropathic pain, the Dollar Neuropathy 4 or DM4. And then we looked at a group of, I would say, more functional tests, so things such as insomnia, severity index, the EQ5D to measure quality of life, and then return to work and return to function. So here you can see the patient characteristics. So in keeping with the literature, most of our patients were male of working age, mainly in either casual or semi-skilled labouring jobs and of white British ethnicity. I think what's quite interesting to point out on this slide is that, as a baseline, our population had quite a high percentage of alcohol and drug use, which obviously is an important factor to consider when you're conducting a study on pain management. and also 7% rate of diabetes, which again can affect your sensory function, particularly in the lower limbs. Of note as well, 3 patients were already on gabapentinoids for pain syndromes, pre-existing. So here you can see reasons for misrecruitment, which I won't focus on too much in the short time available, but the most prevalent reason for not recruiting into the study was another significant injury, which again would have confounded the pain assessment that we performed. So here we can see the mechanism of injury, and again, in keeping with literature, the most common mechanism was a high energy road traffic collision, pedestrian versus vehicle. However, there was quite a range, including a fall from a height of less than 2 meters and other low energy type mechanisms. In terms of the fracture classification, simple fractures were the most common, but we also had some patients with wedge and complex fractures as well. Around 44% had an open fracture, and about 17% of those had quite severe soft tissue injuries. So a Gustilo and Anderson grade 3 injury. So here we can see the surgical management for the patients across the study period. So the majority had 1 operation, and the most common form of skeletal fixation was closed reduction and intramedullary nailing. And we can also see that in keeping with most patients having a simple fracture pattern of a less severe soft tissue injury, direct closure was the most common form of wound closure. However, we did also do temporary vac dressings and a local flap for 1 patient. So here we can see the results of the nerve dysfunction. So it's important to point out that about 23% had impaired or absent sensation at presentation. And these are the monofilament results all the way from day 1 post-injury to up to 6 months. I think the interesting finding on this slide is that actually quite a high proportion of them had sensory loss, so almost 30%. And as you go across to 6 months, although that number improves, there's still quite a significant proportion who have lasting nerve dysfunction or sensory changes. And despite these findings, there was no mention of nerve integrity or damage in any of the operation notes included in the study. And the monofilament testing was done on 5 important nerves of the lower limb, so the tibial, the sural, the saphenous, and the deep and superficial perineal. So here we have the results, again, of the pain outcome assessments. So visual numerical rating scale there from day 1 to 12 months, ranging from between 1 to sort of 5 out of 10. And I think the interesting finding is the dollar neuropathic outcome measurement. So for this particular outcome,
1 minute.
A score of more than 4 is the threshold for a neuropathic pain syndrome. And any less than that is defined as neuropathic pain features, but not a syndrome. And you can see that there is a significant proportion of between 10 and 25% as a percentage of the total study population that actually crossed the threshold of having a neuropathic pain syndrome. And a further 20 to 30% had neuropathic features. So despite that high proportion of neuropathic symptoms, actually most patients in the study received the standard WHO analgesia ladder, which was paracetamol escalating to weak and strong opioids, and only 3 received gabapentinoids as a new prescription for their injury. In terms of the long-term outcomes, again, a significant impact on quality of life, with around a third having mobility problems, difficulty completing their activities, and ongoing pain, anxiety, and depression. And I'll just finish up with some predictions. So having an abnormal monofilament testing in the first week meant that 31% of that group then went on to have a DN4 pain score of more than 4 in months 3 to 12, and 100% of them had an EQ5D pain score of more than 3 out of 5 in months 3 to 12.
Thank you very much. We have to stop it there now. Sorry.
Thanks, Alice. Another great talk. I have a question about your exclusion criteria, actually. So I saw that you had over 500 patients, initially screened, but only 70 recruited. And I understand that sometimes that's due to practicalities. You can't get to the patients and recruit them, etc. But actually, it seems to me that you ended up selecting a sub-study of patients with tibial fractures who happen to not have other injuries, when we know that patients who have tibial fractures often have other injuries because they're high energy injuries. So have you actually ended up excluding the most relevant patients in this population, the 100 patients who have other injuries?
I think it's an important question. I think when you're doing any kind of study, particularly because this was a feasibility study using tibial fractures as a model, you need to get the balance of having a relatively homogeneous population in order to actually determine the effects of an intervention or to assess the characteristics of pain. But then I suppose it also does need to be pragmatic. I think I would probably suggest that in terms of an isolated injury, having a tibial fracture as your only injury, as opposed to other fractures, there is a relatively sizable population that do have isolated tibial fractures. So it will be relevant to them. And that in the future, if we did want to extrapolate our findings of the high prevalence of neuropathic pain, we could go on to expand the population. But as a study of modelling and as feasibility work, I think it was important for us to try to keep a relatively homogeneous population.
Thank you. That's very nice talk. The question I have is, what is your most important advice to the surgical community now that you have found that about 30% of the patients have sensory disturbances early on after the fracture?
I think it's really important, particularly in this new area of surgical research with priority setting partnerships, that we consider to keep looking at things like pain, which are of course extremely important to patients. And I think one of the reasons why perhaps pain management hasn't been so heavily researched is that we have a very protocolized management approach for people with traumatic injuries with the BOSE guidelines, targets to debridement, targets for antibiotics, but very little on how to manage pain. When in actual fact, as we can see from our findings, pain has a huge impact on patients and their quality of life. So the next phase of the study, in terms of advising other clinicians and trying to get an evidence base for practice for analgesia for these patients, which is what I think the question was alluding to, would be to do an interventional study, which we are applying for funding for currently, to see whether or not early initiation of gabapentinoids or neuropathic agents actually prevents chronic pain. And there's quite good evidence that in other surgical fields, for example, prior to hysterectomies or cesareans, initiating gabapentinoids early on after surgery or even before surgery does reduce the incidence of chronic pain.
So you wouldn't choose for a surgical intervention earlier on to decompress the nerve?
I think it's a good question. I think what's also interesting is in our operation notes, that were screened, none of them mentioned nerve injury. So I think perhaps, a greater understanding of assessing for that, if it can be accessible macroscopically, if things like nerve conduction studies would be useful. So I think there is a whole host of pain management questions that are important to patients that we need to look into, which includes both diagnosis and management.
Thank you, Alice. That was a great talk. I was a little bit confused by one of the data points towards the end, and that was that reduced sensation leads to a poorer prognosis. Is there anything that you can say about the character of the pain and whether that leads to a poor prognosis or not?
Yes, so I think that was just at one of my later slides looking at ongoing work. So we obviously need to do logistic regression to further solidify our findings and to look for if there are important relationships between the development of chronic pain and patient factors, injury factors, and surgical management factors. So there are, intricacies in the logistic regression that we need to further go into. So it's just our preliminary findings.
Thank you very much. So next we have Rakshan Kamran, who is an NIHR fellow at the University of Oxford.
Okay, great. So hi everyone, my name is Rakshan. As you just heard, I'm a PhD student at Oxford, and I'm excited to present our work on outcome measurement in thumb-based arthritis. So thumb-based arthritis is one of the commonest hand conditions, It impacts up to 91% of people by the age of 80. Symptoms in thumb-based arthritis includes pain at the base of the thumb that varies day to day and with injury, activity, and even the weather. These symptoms are hard to measure, which is a top priority for the James Lind Alliance, which is a nonprofit initiative that brings patients, carers, and clinicians together to identify the most important areas for research. So we can measure the severity of symptoms in thumb-based arthritis with patient-reported outcome measures, or PROMs. PROMs are self-reported, standardized, and validated questionnaires that quantitatively measure the elements of health that matter most to patients from their own perspective. The benefits of PROMs are well documented and include enhancing communication between clinicians and patients, allowing for the recognition of issues which would usually go unaddressed, improving quality of life, satisfaction with care, and even patient survival in conditions like cancer. This is a real priority for the British Society for Surgery of the Hand and the Federation of European Societies for Surgery of the Hand. But normally, we only administer these questionnaires every few weeks or months in the context of clinical practice or research. This means that we might miss important symptom trends. For example, missing if someone answers differently in the clinic versus when someone is gardening or using their hands. Also, PROMs only reflect the moment in time they are administered. For example, a patient might have terrible pain in their thumb from Monday to Friday when working as a carpenter, but if we ask them on a Saturday, they might actually say the pain is okay. These problems can lead to biased trial results. This also means that some of the benefits of PROMs are lost. So computerized adaptive testing, or CAT, is a form of artificial intelligence that can make PROMs much shorter. CAT makes PROMs shorter and more patient-centered by intelligently selecting only the most appropriate questions to ask an individual based on their previous responses. This means that we might be able to administer PROMs far more frequently, even daily, to help capture symptom fluctuations. To give an example of how CAT works, let's say an individual completes a PROM which assesses pain with mobility. If this individual reports pain with walking, we can estimate that this person has pain with running and jumping. At this point, it isn't useful to ask every single question in the PROM. It's more informative to ask questions which discriminate between pain associated with lower levels of mobility. CAT does this intelligently. So CAT is a balance between burden, which is asking too many questions, and precision, where the more questions you ask, the more precise your result becomes. We can find the balance by looking for reliability statistics like standard error of measurement, or SEM. We used a threshold of SEM of less than 0.3, as this is a common rule of thumb in literature and roughly equates to a reliability of 90%, which is considered an excellent threshold by some people. So we aimed to make a computerized adaptive testing algorithm for the patient evaluation measure that would allow us to capture symptom trends in thumb-based arthritis. To build our algorithm, we used data from the British Society for Surgery of the Hand UK Hand Registry. This included around 1,600 responses to the 11-item questionnaire completed by over 900 patients. We then applied CAT to a simulated data set to see whether it could accurately reproduce full-length PEM scores from fewer questions. To create a CAT, we used a CAT algorithm developed in R. We simulated 1,000 complete response sets to the full-length PEM questionnaire. For each simulated respondent, the CAT analyzed item responses one at a time. The CAT predicted the respondent's total score after each item response and then selected the next most informative item to administer. This continued until a score precision of SEM of less than 0.3 was met. At that point, the CAT stopped administering items and moved on to the next respondent. We found that our algorithm could reduce the length of the PEM questionnaire from 11 questions to between 1 and 4 questions per assessment. The median number of questions needed at each assessment was 2. At this assessment length, the CAT was able to reproduce the full-length PEM scores with a high level of accuracy. CAT scores were within about 10% of the full-length questionnaire scores, but from a fraction of the total number of questions. So we checked the reliability of our CAT algorithm using standard error of measurement, and we found that assessments had a high reliability with a SEM of less than 0.3. This is comparable to the popular PROMIS CAT systems, which are available through the EPIC electronic health record platform. Our instrument is likely to be even shorter than PROMIS measures. The CAT works particularly well when we are taking the averages of populations. For example, in a trial that compares 2 different treatments. In those cases, the error is only 0.2%, which is negligible. The CAT is also useful for replacing questionnaires for individual patients in front of you in clinic. For any one patient you might see in clinic, the error is around 4.5%, which is also very small. This shows that we can use this technology both in research to compare groups of people and for individual patients that we want to monitor through a smartphone app in clinic. We are now working to operationalize this software as a smartphone app that could be used for more granular data capture and research, and even in remote patient monitoring in clinical practice. So you might be able to track what's happening to your patient's symptoms after an injection or a trapeziectomy, and arrange for early targeted interventions like physio or splinting for people that aren't progressing in the way that you hope them to. We also hope that by capturing patient-reported outcome data in a person's natural environment, for example, while gardening or preparing food, we might be able to get a truer reflection of their symptoms than if we were asking them these questions in clinic. The application of this technology for remote patient monitoring might also be beneficial in the peri and post-COVID era. So that's all from me. Thank you so much for listening, and you can email me if you have any questions we don't get to.
Thank you very much, Prashant. Really nice presentation, very clear as well. I have a question about actually the burden I think you've basically answered this question, but the burden that this would then put onto the patient to have to track these things daily. Is there a way of easing that? Can you think of any sort of technological interventions that can ease that burden, that people don't really have to be inputting things into their smartphone every day?
Yeah, I think that there are a few different sort of points along the completing the PROM course where this could have been done. So I think firstly, when you're counseling the patient, explaining that, we get the most benefit when we get more responses, sort of psychologically explaining them the rationale of why we're asking them to complete these questionnaires. And then secondly, I think when they actually complete the questionnaire, possibly having automated notifications for certain time points to complete the PROM on a smartphone might help ease the cognitive burden of going, okay, now I have to log in to complete this. I can just respond to this, notification, complete these 2 questions, and it's done. So I think tackling it sort of with that strategy, counseling plus the notifications, might be a good way to move forward.
Right. Or maybe using Alexa, something like that.
Oh, yeah. Yeah. Next study.
Yeah. Okay. Thanks.
Thank you very much for this very interesting talk. I was wondering, do you obviously you're very enthusiastic about the way that you were taking the PROMs, but what do you think is better, to move in the direction that you're heading to, or to go to the more patient-specific function scoring?
Yeah, are you speaking about using condition-specific measures versus generic PROMs?
Yeah, just if you can ask somebody, what is your major complaint? When do you have the most pain? And then you can follow the pain that they have during that activity and see how it responds to your treatment.
Yeah, I think that the whole purpose of this is so that we can get more frequent assessments. So exactly like you mentioned, so when people are working and they're in the most pain, versus also when, they might not be using their hands, and seeing, okay, is that pain still present? And if so, how does that inform our management? So I think that sort of goes back into the counseling, and then also deciding at what time points to administer this PROM. So that whole sort of question about when do we best administer this PROM is part of implementation and thinking about how we implement PROMs in clinical practice. And that's something that we're going to be looking at in the future, actually, at what time points are the best, so that patients can give us the most meaningful data.
Thank you.
Thanks, Rakshan. Very good talk. I wanted to ask you, what's the probability of escape from the right question in this kind of stratification of questions?
Yeah, so when we sort of measured the comparison between the CAT and the full-length PAM questionnaire, we found that responses were similar with about 10% degree of error. So about 90% of the time the scores would be the same. So we found that, using that reliability statistic cutoff, you can actually set the CAT to stop asking questions for the precision rather than after a certain number of questions. So that's the approach that we took. So we actually found that the CAT that we used was actually quite precise and comparable to the full-length PEM questionnaire. And then another thing that we also looked at is in previous CAT research, they've actually looked at if the order of items administered affect the total score at the end. And prior research has shown that the order of questions administered does not impact the final score.
Thank you very much. Next presenter is Gino Vissers. He's from the University of Antwerp, University Hospital Antwerp in Belgium.
So my name is Gino, and thank you for giving me the opportunity to present our study here. The study that I'm going to present is a project that we did at Chelsea and Westminster Hospital together with Imperial College in London. And it's taking us quite back to basics. It's a study looking at different needle types that may be used in tendon repair. So let's start with a brief introduction. So you have different types of needles, including cutting needles who cut a pathway through tissue. And you can see them right here on the right top image, because they have like sharp edges on the side. And another type of needle that we have are round-bodied needles. They don't have the sharp edges and they pass through tissue by stretching rather than cutting the tissue. And it has been thought for many years that round-bodied needles should be used for tendon repair as they may be less traumatic. And most of us do so. However, when we look at the literature, we could only identify one animal study with swine tendons supporting this data, and there are no other studies regarding this matter. So the aim of this study was to evaluate whether the choice of suture, and more specifically the choice of needle type, affect the failure load of the failure mode in a human model. When we look at the methods of our study, we did a human cadaver study. We used 40 FDP tendons and we randomized all tendons in two groups. So 20 tendons were repaired with a cutting needle and 20 tendons were repaired with a round-bodied needle. And all tendons were subjected to a cyclic tensile testing. If we look at the tendon specimens that we used the FDP tendons from index, middle ring and little fingers from 6 males and 5 females with a mean age of 56 years. And all repairs were carried out at Plexus zone 3 using a Prolene 3.0 suture as recently published in the Journal of Hand Surgery. This suture might give the best knot stability. We performed a core repair with a 4-stranded Adelaide core suture and no epitendinous repair. I'll get back to that later. This is a visual image of the repair that we performed. So it's an Adelaide core suture with distances of 7 and 10 millimeters to the repair site, respectively. If we then look at the biomechanical testing that we performed, we used a cyclic tensile testing using an Instron tensile testing machine. And the tendons were loaded with sets of 500 cycles, as this is believed to correspond to 5 to 10 days of active rehabilitation. All the tendons were preconditioned with a ramp load of 10 newtons and 10 newton increments were used for each set. And at the end of each set, the gap formation was measured at the repair site. During the testing, failure was defined as no resistance against elongation or a clinical gap formation of more than 2 millimeters. The failure load was the load at the failure point, and the failure mode was assessed by direct observations and was either a suture rupture or a suture pull-out. So this is the setup of the test setting. You see the Instron machine with the loading cell, the freeze clamps that hold the specimen, and the specimen was mounted with the repair site centrally between the two clamps. The results that we got, so we had the 40 FDP tendons in total, and both study groups consisted of 5 index, middle ring and little fingers each. And for each tendon, a time elongation graph was made. And you can see two examples here. So the orange specimen is a repair that was done with a round-bodied needle. And as you can see at the end of the graph, there's like a gentle ending of the curve. Whereas if you look at the blue curve, you see that there's a more abrupt ending, which resembles a suture rupture, whereas the orange ending represents a suture pull-out. If we look at the failure load between the two needle types, you see that there's no difference between round body or cutting needles. The mean failure load was about 50 Newton for both types. However, if we look at the failure mode, we see that there was an important difference, namely that suture pull-out happened way more frequently in round-bodied needles than in cutting needles. And the opposite was true for suture rupture, which happens way more frequently in cutting needles. During the study, no knot failures were observed. So what do these findings mean? That there's no difference in failure load means that there's like little clinical impact, but there was like importance in failure mode, and the explanation for this might be the different cutting mechanisms in relation to the tendon fibers. The round-bodied needles separates the tendon fibers and creates a potential passageway for future pull-out, whereas a cutting needle cuts the tendon fibers, and the hole that is left by the cutting needle gives a wall of tissue that gives resistance to the suture and prevents the suture pull-out. However, when we look at the separating fibers and we look at the literature, we see that Frick examined the resistance forces on the straight to a cutting needle passing sheepskin and sheep Achilles tendon, and they showed that even a cutting needle separates the tendon fibers, and that might explain why still 1/3 of the samples repaired by cutting needles had a pull-out mode of failure in our study. Another thing that is interesting with cutting needles is that they are more prone to needle-induced damage. It has been demonstrated in cutting needles, and it's mainly because they have like a sharp tip, and with every passage that you do with your needle, there's an increased risk of damaging the suture that you just put in. And that might explain why cutting needles make a repair more prone to suture rupture than round-bodied needles. There are a few limitations to our study. So firstly, of course, it is a cadaver study, which is unable to represent the complex physiological processes that's going on in the human being. However, when you look at the literature, you see that these biological strength only happens after 5 to 10 days. And that's why we chose for a 5 to 10 days representative cyclic loading protocol in our study, because until that time, the repair of your tendon mainly relies on the strength of your suture. Another limitation was that no epitendinous repair was performed, and we specifically chose that because we didn't want to have any bias from the damage with the cutting needles. But because most surgeons would use an epitendinous repair in clinical practice, caution should be taken in directly extrapolating the study outcomes to your practice. So far the discussion, and I would like to thank you very much. It was a quite different study with respect to the other papers, but I hope that it may give you some insight in like the basic science and let you think about what we're actually doing all day and what evidence we have for that.
Thank you very much. A very interesting study, and I did kind of wonder why you decided to embark on it in the first place when we know that round body sutures seem to work, but I do understand some of the rationale now. I've been wondering whether actually you would say that with less experienced surgeons, where they're not taking the bite straight away in the right plane, the right time, using a cutting needle is potentially damaging, because when you take it out and go back in again, then you're creating more and more trauma to the tendon itself, and whether that in of itself is a very good reason not to use cutting needles, regardless of the strength and failure data.
Yes, I think that plays an important role, and it might be interesting to examine it in another study where you compare like junior doctors or junior surgeons and very experienced surgeons to see whether there's a difference in the amount of damage that is caused to a tendon, mainly by the sharp tip and edges of a cutting needle, because it might be that is like a relevant factor. Yes. Thanks.
Thank you, Gino. I was wondering what exactly is your plan for the next study?
Well, one of the limitations is that this is a human cadaver study and that we don't examine it in a living being. It is a huge advantage that it is the first human study regarding this matter, but I would like to do like a randomized controlled trial with round-bodied and cutting needles and see whether there's actually a difference with clinical impact between the two needle types in actual repairs in actual patients.
Okay, thank you.
Thank you, Gino. Very interesting. What do you use?
I use round-bodied needles just because all my teachers have taught me so. And the repairs work well. So yeah, I think we just need to do like further research to see whether there is any difference. It might be that there is even none.
Okay, so last presenter is Justin Wormold. He's an NIHR doctoral research fellow at the University of Oxford.
First off, thanks to everyone for the invitation to talk. It's a great privilege to come back to the symposium and present my work that I'm doing as part of my PhD. No conflicts of interest, really. These are the people that have funded me. So the National Institute of Health Research currently funding my PhD. I've had funding from BSSH and the Royal College of Surgeons. And the last disclosure is that I do have a cough, but it's not COVID, and also it's virtual, so you don't need to worry about it, all being well. So what I'm really interested in is hand trauma. And obviously with this audience, I don't need to explain what that is, but I just want to talk to you about a little bit about what I've learned about hand trauma in the work that I've done so far. And there's these pretty striking figures that are out there. So this is just UK figures, and I appreciate this is an international audience, but in the UK, there are about 5 million injuries per year that occur to the hand and wrist. And then that results in 250,000 operations per year. So what does this tell you? Firstly, that hand trauma is really, really common. Secondly, that we do loads of operations for hand trauma every year. But it also tells you that many injuries that we see are managed non-operatively. And I think many of us know that, particularly closed injuries. And as we also know, many injuries can have surgery or they can be managed without surgery. These are the discussions that we have with patients quite a lot. And when you have a discussion with any patient about having an operation, we talk about the risks of surgery, right? So we talk about infection, pain, bleeding, scarring, and then all the specific complications that occur with that particular operation. But yeah, I mean, infection's up there, isn't it? It's one of the first things that we mention when we're consenting patients. So what do we tell these patients? You know, what is the risk of infection in hand trauma after surgery for hand and wrist trauma? Is it 1%? Is it 5%, 10%? I don't really know. And I've never really known and felt that was a bit of an issue. And that's why I wanted to look at this in a bit more detail. And I have looked at it in a literature review when I was preparing for my grant applications. And actually, there's very little accurate data on what the risk of surgical site infection is after this. And that's pretty amazing considering we do 250,000 operations a year. We still don't really know why people get infections, how common it is, and what we need to do about it. And the reason this is important is because actually that means that the knock-on effect of this is that we have very little evidence for interventions to reduce infection. You look at general surgery, vascular surgery, there are many trials comparing different interventions to reduce surgical site infection. But for us, we don't have that. How do antibiotics work, surgical sterility, antimicrobial sutures, antimicrobial dressings? We use these things. We don't know if they work. NICE, so National Institute of Health and Care Excellence in the UK, reckons infection rate is about 2 to 5% across all surgical specialties. But we know this is a gross underestimation because many of these are not recorded well in the notes and they're not picked up in the same hospital. And therefore, this is generally known to be higher than this. And we have no idea what it is in hand and wrist trauma surgery. So how do I find out? Well, the first step is to do, as with all things, a systematic review. And that's what I'm going to talk to you about now. So the first thing I wanted to know is what is the risk of surgical site infection or SSI in the published literature? And so we set about to do a kind of mega review, a mega systematic review, meta-analysis of all primary studies of surgery for hand or wrist injury. So any study that looked at a surgical intervention for hand or wrist injury that reported infection was eligible for inclusion. I searched the most common databases for hand surgery research, Medline, M-Base, Senal, Central, and the trials database. And what I was really interested in was how these studies defined infection and also what the incidence of infection was in that population that was studied. So here you go, Prisma flowchart. Familiar with this? I've summarized the key figures. So we screened 8,000 abstracts and reviewed 221 papers for eligibility. So that's full text reviews. And ultimately we included 171 studies. So this is a massive review. This is the biggest review I've ever done. And it was a lot of work. So into the data. So 171 studies, as I've said, a total of 30,634 patients, of which 27,607 received surgery. So there were non-operative arms in some of these studies as well. As we expect, vast majority case series, but still quite a lot of cohort studies and some trials. So that was useful and that was good to see. Very few case control studies. And 21 were only abstracts, so I couldn't really be sure what study design they used, and so I didn't really include them going forward. In terms of the anatomical site of the injury, so mostly hand, about 60% hand. Some studies had both hand and wrist injuries included together. And looking at the type of operations that were delivered, so a good mix. So bony fixation in well over half, in sort of almost 80% of the studies that I looked at, with ORIF, KY, X-Fix. And then a lot of soft tissue repair as well, so 21% soft tissue repair. So what is the risk of infection after these operations? So here is a data table, and this shows you the medians of various sub-analyses that I've run on this data. Overall, the risk of infection was 4.2%, so that sits quite nicely within a nice estimate, right? So that's similar to other surgical specialties. Massive ranges throughout all of these, but to be honest, I'm expecting this. This is a heterogeneous group of studies, so we expect to see wide variety. What I thought was really interesting is a couple of findings in particular. So RCTs, the risk was 12%, the median risk, that's pretty high. In the larger prospective studies, this was also mirrored in 10.5%. And what that tells you, I think, or the way I've interpreted that, be interested to discuss, is that when you're doing a prospective study, you're recording surgical site infection accurately, you're finding a higher rate. When you're looking back through the notes, it's not well documented, might be some selection bias going on, or they've gone elsewhere for an infection to be treated for their infection. So I trust these studies more, and I think that the rate leans towards a higher rate than we expect and higher than the overall median. Equally, you'll see that the rate of infection was, or the risk of infection was higher in wrist, but that I think is really reflected by the large number of studies of KYs and X-Fix in the wrist, which had higher incidences of surgical site infection, although many of these were pin site infections, so towards the more minor end of surgical site infection. So we've done this massive review and I haven't really found a good answer, a reliable answer, but I think there have been some interesting findings and it's an interesting view of the literature as it stands. I think the SSI risk is probably similar to other surgical specialties. Therefore, we should proceed and start to investigate interventions to reduce surgical site infection as they have done in other surgical specialties. I think the rationale is there. We used to say, I've been taught, that the hand doesn't get infected because it's got such rich blood supply, but I don't think that's true, looking at this data. Importantly, and I know this might be a question that's going to come, the definition of infection was poor. So only 1% of studies use the CDC classification for surgical site infection, and less than 10% of the studies used any definition of surgical site infection in their study. It was just, there was infection. So just to sort of move towards the end now, I just want to show you how this review fits in with my DPhil, and this may be a meme that some of you are familiar with. So yeah, we've done a single center study. We published that last year looking at surgical site infection, and that was interesting. Again, that showed the effect of COVID. This is where we're sitting now. So a systematic review of all primary hand trauma studies. What I'm working on now is using routinely collected healthcare data, so hospital episode statistics and primary care databases to look to get some much larger data sets to get some fairly accurate measures of severe infection that needs readmission. But ultimately what I want to be doing is starting to develop some high quality trials in hand trauma with a view to reducing the risk of surgical site infection for our patients. So I'll finish there. Be grateful for questions, and thank you very much.
Thanks so much, Justin. That's great. Can I just clarify a couple of things? When you talk about surgical site infection in hand trauma, are you talking about a new surgical site or the actual traumatic wound? And how do you differentiate between those two in all the studies that you look at? Because it's a closed hand injury, and opening up an incision there is very different to an open fracture, isn't it?
Absolutely.
What do you mean by SSI?
So SSI, for the context of my entire PhD, is a post-operative wound infection. So yeah, open wounds, then go to theatre, are operated on, closed. Usually, if they get an infection, that's an SSI. But you're right.
Cohorts, aren't they? They're very different cohorts.
Oh yeah. I get that. I fully appreciate that, and that is picked up in this data. So there's more data I didn't show you, but for example, the risk of infection after ORIF is like less than 1%. It's 0.2%, and that just shows you that actually these patients who have closed fractures, they go to a sterile theatre environment, have a clean surgical incision and an ORIF, have a low risk of infection. So yeah, it is quite heterogeneous, and I want to show that because equally, when we start to develop trials of interventions, we don't need to be doing testing antimicrobial sutures on ORIF, because actually infection is just not an issue. There are other things which are more important. But this is the baseline thing to determine what are the risks of infection in these different operations.
Sure. I think I just find the term surgical site confusing when it can just be a traumatic wound, which is not actually the surgical site.
Would you say that it's surgical site if it's operated on there?
Yeah, well, I think yes, but a simple washout is of a traumatic wound, if you want to call that an operation. Does that convert it to a surgical site? I'm not sure.
For me, it would, simply because from a health economic point of view, they've gone to theatre, they've had a surgical intervention, and the surgical site infection. The definition of surgical site infection is that it's a healthcare acquired infection, as opposed to a non-healthcare acquired infection. Therefore, it's potentially preventable. And the idea is you take them to theatre, you clean them up. If they get an infection, that's a surgical site infection. It's not an infected wound that's presented to you. That's the difference in my mind. But I agree, it's not clear, and that in itself is worrying, considering how common this is. 250,000 operations a year, and we still don't really have that nailed down.
Thanks.
Thank you, Justin. Very interesting work. I was a bit surprised that you put all your apples and pears into the same basket and then take the mean or the median country member and come to 4.2%. And the reason for that is that I think that obviously as you already alluded to, the RCTs and the prospective studies, those are the studies that give us the best results. So why don't you stress that more, that actually the 4.2% is not the percentage that we should be working with? It's much more towards the 10 or 12%.
Yeah, thanks, Professor Worker. To be honest, I think you're right. I think there's definitely, this work isn't finished yet. It's not published. I'm still working through the discussion of this data, and I think that's a really important point. When I had that big data set in front of me, I really wanted to pool it and see what it was, because I was just curious. But I think you're right. That number is actually pretty meaningless. And if you look at the range 0 to 47.1, it's hugely, there's huge variety in the data. I think that the crux of my discussion will be, if you design a study well to look prospectively for surgical site infection, the rate is probably over 10%. Yeah, I completely agree. And actually, I think that 4.2 is fairly meaningless.
Thanks very much.
Thank you.
Interesting talk, Justin. Very good. I just wanted to kind of quiz you about the cost economics of the morbidity associated with an SSI and the cost economics of not operating and being left with a deformed finger. In this kind of cost-stricken NHS system that we've got just now, what do you think is the right thing to do?
All of the work on SSI and cost of SSI is not done on hands. It's not done on plastics. It's done on laparotomy, and therefore these infections are associated with extremely high costs in the eyes of NICE, Department of Health, and an IHR. And that doesn't really reflect a simple wound infection after a flexor repair that needs a week of antibiotics, which is actually very cheap, or even a pin site infection after a KY fixation of the hand. I think the answer is, and it's a bit of a cop-out maybe, but I think we need to look into that in a bit more detail. Firstly, we need to look at what the effect of SSI is on hand recovery, and is that severe? And I'm hoping to do that in my trial. I'm collecting some PROMs and SSI. I'm going to see if there's any link between, if you get an SSI, does that actually make your hand function worse, or is it actually fine? I think that's the question we need to answer. And secondly, how much does SSI cost in hand surgery? And I think that may be very different to what it costs in the eyes of NICE and Department of Health.
Thank you. So now the judges will convene for a few minutes.
Great, welcome back everybody. So a fantastic session, and I wondered if Professor Govilkar, you can give some comments about the presentations we've all heard. Thank you.
Well, first of all, I would like to say that that I really enjoyed the whole session from the very beginning. I had the pleasure of hearing Professor Sabapathy a few years ago when I attended one of the Manchester hand courses, talking about his incredible experience in replants. So I was very happy to see and hear him again and give his talk. And obviously all the other talks were also very interesting, and the 6 presentations that he had at the end, as I said, it is becoming quite complex for me to follow some of the presentations because I'm just a simple surgeon. But it is impressive to see how research has evolved in the last 20 years or so. So we are really getting into the next stage where what we are doing will becoming more and more evidence-based. So I'm really impressed. Thank you very much.
So now we have the results, and Dr. Sabapathy will announce the winners of this year's Stoke Mandeville Ganga prizes.
Right. Thank you so much. I think this is an important time. And as the judges told, and I was also very extremely interested to listen to all the papers, because they range from basic sciences to like tendon repairs to surgical site infections to using sophisticated statistics to help us patient outcomes and to make the decisions. And I was also happy for another thing, Rebecca, because I was only the chairman and I was not the judge. So I mean, in that way, I was pretty happy because I could listen to it happily. I don't really have to put in all my thoughts. And I think the hard work was done by Jason, Fanny, and Marka. So that was also nice. In fact, I should tell, I was more interested in anticipating what the questions these judges are going to ask, as much as I was listening to the papers. I think that was very interesting. So I'm sure they had a pretty hard time, as shown by the results. I think we should. Normally, people come back from the 3rd prize to 2nd prize.
Right, I think we have everybody we need.
Sorry, Dr. Sabapathy, please continue.
Yeah, Rebecca, I think you're doing some conspiracy. I think it means you're making it more suspenseful than the Oscars. And then the prize goes to Stoke. Right. No? So I think, as I told you, I think, can I continue? Yeah, I think people are there. Right. So I think the judges must have had a very hard time, and so they're given 2 joint first prizes. That's fantastic. And joint first prizes go to Lisa Hugendam from Erasmus University. Right. I think I really enjoyed your talk of the single machine learning model. Can it accurately predict post-treatment pain improvement in 26 hand and wrist conditions? And also loved the way you answered the questions. And the person who will be sharing the joint first prize is Luke. And for the paper predicting improvement in hand function and symptoms following carpal tunnel decompression. So I think that was the first paper which you had. I think probably since you were the first, you were asked a lot of questions. Yeah. And you handled them very well. And on behalf of us, both of you will find a place in our Ganga microsurgery course now. The travel has opened up. We have a lot of visitors coming in now. So both of you are most welcome for the microsurgery course, and we'll be too happy to have you. And the second prize goes to Dr. Kamran, and for his paper on computerized adaptive testing of the patient evaluation measure. Questionnaire is accurate in thumb-based osteoarthritis from as few as 1 to 4 questions. So congratulations to all of you. Kamran, you are most welcome, and we'll send you the link for our hand surgery live surgery workshops, which usually comes up in June and July, and where we have about 25 to 30 live surgery cases being done. So thank you so much, and I think congratulations to all of you, and also to the people who missed it. I think you need to have it the next time. And for the judges, on behalf of James, Rebecca, and Jeremy, and everybody, I thank for the hard job they did. And they did it very consistently and well. So thank you so much. And I'm sure we'll be too happy to meet in the next edition of our Stoke Mandeville Ganga Symposium. Thank you so much. And over to you, Rebecca and James.
Thank you very much. So this does bring us to the end of the symposium and the end of 2021. We've had a lot of fun along the way, and we hope that you have as well.
And we're really excited to build on our connection in 2022. We want to continue to bring you the innovations that transform our ability as reconstructive surgeons to make a real difference for our patients.
We would like to thank our sponsors, our speakers and chairs, and although he doesn't want the thanks, our technical guru, George Adigbali, has been fantastic. It's been a very ambitious task that we've asked of him today. And also thank you to everyone for joining us. So Merry Christmas and Happy New Year, and we'll see you in 2022.
Take care.
Bye-bye.
Well done.